Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I think we would start so we can give enough time for all the speakers to present their talk. Thank you so much for being with us today. We are so excited to have our third Best of San Antonio Breast Cancer Symposium in Dubai. I'm honored to co-chair it with Dr. Al-Khair, who is the chair of the San Antonio and the MENA region. Again, welcome all. Thank you for being with us here very early. I think before we start, I would like to call our President of the Emirates Oncology Society, Professor Hamid, to give a small talk, and then we introduce Dr. Al-Khair, our chairperson, for this session.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure to be here today, and thank you all for coming early in the morning. Dr. Al-Khair, thank you for supporting the initiative a few years back to host the San Antonio here in Dubai in UAE. So thank you again for all the support. I would like to thank all the members of the Emirates Oncology Society. I would like to thank everyone who came abroad from outside the UAE. I would like to thank our sponsors. I would like to thank conveners for their support also. And I will not take too much time. I would like to invite Dr. Al-Khair to give us a small talk as well before we start the event. Assalamu alaikum.
Assalamu alaikum wa rahmatullah. First, I would like to thank Dr. Hamid and Dr. Aida for hosting Best of San Antonio for the third year this time. In Jeddah, we 19 years, and we just celebrated the 19 years of Middle East Best of San Antonio, but unfortunately, not everyone can attend, and many faces I didn't see in our Middle East Best of San Antonio, which was done in January, just a month ago. So I'm glad to be here for the third year, and without further ado, I would like to introduce the first session, which will be advances in biomarker-driven. And the first speaker for the session is Dr. Hala. Dr. Hala, she's an oncologist, graduated from Alexandria University, Faculty of Medicine, Egypt in 1994. Dr. Hala, she is Associate Prof at Alexandria University as a clinical oncologist. She had her master's degree and PhD from Egypt, FRCR from London, and European Certified Medical Oncology from Austria. Dr. Hala has more than 25 years of experience in treating all types of cancer. She has been working in UNE since 2001, first at Al Mafraq Hospital, then joined Al Noor Hospital in 2008. She has a lot of international publication and is very active member of weekly tumor board screening program and local and international conferences. The floor is yours.
Assalamu alaikum. Good morning. Thank you so much for inviting me for the Best of San Antonio. Thank you for all the leaders. Thank you for Mr. Chairman, Dr. Al-Khair, Dr. Aida, all. Without further ado, I want to present my first presentation today. It's about neoadjuvant HER3 deruxtecan alone or in combination with letrozole for high-risk HER2 positive, hormone receptor positive, HER2 negative in early breast cancer. The primary results of the randomized phase 2 Salty Valentine trial, which was accomplished in Spain, Barcelona. So this is a disclosure. Some backgrounds. Multi-agent chemotherapy improves survival outcomes in high-risk hormone receptor positive, HER2 negative in early breast cancer. However, there remains a need for more effective and tolerable strategies in this context. HER3 deroxytecan is a potential first-in-class HER3 directed antibody drug conjugate with activity in multiple breast cancer subtypes. In SALTI taught HER3, a single dose of HER3 deroxytecan, patritumab deroxytecan, was associated with increased cell TIL score and clinical response in patients with hormone receptor positive HER2 negative in early breast cancer. So hypothesis that HER3 deroxytecan, either as single agent or in combination with letrozole, is an effective and safe neoadjuvant treatment option for women with treatment-naive, high-risk hormone receptor positive HER2 negative early breast cancer. So this is the SALTI Valentine's study design, which is a parallel, randomized, non-comparative, open-label phase 2 trial, was accomplished and done in Barcelona, Spain. So we have the number of patients included, 120, key eligibility criteria, pre- and post-menopausal, women or men, primary operable breast cancer, 1 centimeter or more by MRI, hormone receptor positive HER2 negative. Ki-67 was 20% or more, and or genomic risk, genomic signature. No prior treatment for the current breast cancer, and available pretreatment core needle biopsy was needed. So the study design that we have, we start a baseline core needle biopsy. Then the design was randomized into 3 arms, 2 to 2 to 1 in a percentage, and stratified by nodal axillary status also. So the first arm, we use single agent HER3 deroxytecan, 5.6 milligram per kg, Q21 days for 3 cycles. The second arm was HER2 deroxytecan with letrozole, 5.6 milligram kg, Q21 days for 6 cycles, together with oral letrozole 2.5 milligram, with or without ovarian suppression function according to if the premenopausal status. So and then the third arm was our standard multi-agent chemotherapy, EC or AC, 14 days or 21 days by 4 cycles, followed by weekly paclitaxel 80 milligram per meter square for 12 weeks. So this is the study design, and then after the first cycle, in the cycle 2, day 1, we have to go for another tissue biopsy from the same cancer, and then we go through the treatment option, and then the surgery was done. So our aim is the primary endpoint is the pathological complete response, YPT0IS, YPN0 at the surgery. Our secondary endpoints were objective response rate, cell TIL score changes, Ki-67 drops, and PAM 50, which for that 5 types of the breast cancer, and risk of recurrence, safety, and invasive disease-free survival. So the Valentine salted our samples was not selected to formally compare treatment arms in terms of pathological complete response rate, but to achieve a certain level of precision estimating PCR in each arm. Assuming a PCR of 20% in HER3 deroxytecan arm, a total of 48 patients per arm would provide a precision estimate of 11.3% using asymptotic two-sided 95%. And the chemotherapy treatment arm was included as an internal response control. It was the comparable arm, and to recruit to the right patient population. So for the beginning of the study, we assessed around 154 patients, and then exclusion was 32 patients. We have 8 patients because of the consent withdrawal, metastatic disease in 9 patients, no treatment biopsy, no pre-treatment biopsy in 2 patients, and then others in number 13. So at the end, we include 122 patients. They are divided into 3 arms, 2 into 2 to 1. 50 patients, 48 patients, and 24 patients. And then for the first arm, 50 patients included at the time of surgery. We have 1 death, but was not related to the treatment. And then the second line, it's 48 patients during the treatment go to surgery. And then the third arm, we have 1 disease progression, so was removed from the study. So this recruitment period from November 2022 to September 2023, and data cutoff was April 22nd, 2024. Then the other half of the slides, we can see that the patient basic characteristic was comparable between the 3 arms. We can see the age of the patients, almost all 50, 51, 49, 52. Then the female premenopausal status. And then for the stage, we can see that T3, T4 in the 42%, 40%, and then 29%. For the staging, stage 2, almost comparable, stage 3, almost on the same percentage. For the HER3 immunohistochemistry, we have the high level. It was 80% in the first arm, 83%, and then 88%. Intrinsic subtypes, according to the PAM50, we have the 5 subtypes: basal-like, HER2 enriched, luminal A, luminal B, and normal-like. And the most important were that luminal A and luminal B. So for this, the study there, we can see that for the first arm, the pathological complete response rate, it was seen in 4% of the HER3 deroxytecan, and then 2% in the HER3 plus letrozole, and then compared to the chemotherapy arm, it was 4%. So almost the same percentage between the first arm and the chemotherapy, the comparable arm. Then objective response rate, again, it was 70% for the first arm, 81% for the second arm, and then 70% for the chemotherapy arm. So it's almost the same for the comparable study. And then progression disease, we have only 1 patient and 1 patient. So the overall, we can see that the response rate was 3.3, and then the objective response rate reaching 74.6%. Again, we have to check the KI 67 because it was one of the secondary endpoints where we can see that it's a drop at cycle 2, day 1. That's why we have to go for a biopsy again on cycle 2 to see the tumor criteria and the response of the treatment after the first cycle. So here we can see that the K67 was dropped at the beginning, and then it was dropped after cycle 2, day 1, and then at the surgery time. So we see more drop of the Ki67. Again, for the second arm, the HER3 deroxytecan with letrozole, there is a marked drop also of the Ki67, and then compared to the chemotherapy. Switch from PAM50 luminal B to less proliferative luminal A, normal like at the surgery. So this is what we can see also, that the following changes also observed in HER3 deroxytecan and HER3 deroxytecan with letrozole arms. Significant changes in cell TIL score from baseline to cycle 2, day 1, and from baseline till the surgery. Association of cell TIL changes from baseline to cycle 2, day 1 with radiological response. Also, shift from high, medium risk of recurrence scores at the baseline to low risk of recurrence scores at the surgery time, and also in chemotherapy arm. Regarding safety and tolerability, all treatment-related adverse events, where we can see it's for any grade was almost in the first 2 arms was 48-47%, but higher grades like grade 3 and 4, it was very minimal, 7% compared to the chemotherapy arm, 11%. Also, we have treatment reduction for the during the treatment if we need to reduce the treatment. So only 3%, 4%, 9% in the chemotherapy arm. Treatments interruption, it was also very little, 6% in the first arm, 2% compared to the 12% in the chemotherapy arm. Treatment discontinuation, it was 0 in the first arm, and then 2 patients, or 4.2%, and then another 2 patients in the chemotherapy arm. So that this is the non-hematological treatment-related events, where we can see mainly the fatigue is high in the chemotherapy arm, nausea, alopecia. Also, we can see in the second arm, because we are adding hormone to the deroxytecan, and then the other diarrhea were going down and can be controlled. For the grade 3 and more treatment-related adverse events, less frequent in HER3 deroxytecan arms, less treatment reduction, interruption, and discontinuations in HER3 deroxytecan arms were needed. No ILD cases were reported, no treatment-related deaths were reported, and 1 patient not related to the treatment arm. Regarding the hematological toxicity, so where we can see the neutropenia, it was higher in the chemotherapy arm, anemia again higher in the chemotherapy arm, and the others were more comparable and very less grades. So in summary and conclusions, Valentine salty treatment, it's a positive trial that we can see that treatment with HER3 deroxytecan with and without letrozole, it achieved comparable PCR rates and or objective response rate estimates to those seen with multiple agent chemotherapy. In high risk, hormone receptor positive, HER2 negative early breast cancer, HER3 deroxytecan showed biological evidence of anti-tumor activity. We have drop in Ki-67, switch to less proliferative PAM50 subtypes, decrease in risk of recurrence, and increase in cell TIL scores that correlate the treatment response. Treatment with HER3 deroxytecan associated with a lower incidence of grade 3 or more treatment-related events and reduced rates of dose reduction, dose interruption, or even treatment discontinuation compared to multi-agent chemotherapy. So again, we can see that the salty Valentine was a positive trial, and we support the effectiveness of HER3 deroxytecan in early breast cancer and its potential incorporation in the treatment of high-risk hormone receptor positive patients, HER2 negative early breast cancer. Thank you.
Thank you. No, stay. We will take a question. Thank you for being even before time. This is a good start. So the floor is open for questions. If no questions, Dr. Hala,
yes.
We saw that there is results in all subtypes. So
yes.
Do you think that we will need BAM50?
Sorry?
Do you think that it is going to be mandatory to have BAM50 to be done for all patients before we use it, or during?
Yes, BAM50, it was one of the scoring system was done in this study before we start the neoadjuvant chemotherapy of the patient. And of course, if it's available for in our country, so we have to go for it because it's one of the criteria. Yes, we can go for it if it's can do.
If no questions, thank you. And
thank you.
Thank you, Habibi.
Thank you so much, Dr. Hala. That was an excellent presentation. We'll move to the next speaker. I think he doesn't need any introduction. My colleague and dear friend, Dr. Arif, who's a consultant medical oncologist and expert in breast cancer at Sheikh Shakhbout Medical City. Welcome, Dr. Arif.
صباح الخير. السلام عليكم. Thank you, Dr. Aida, for your kind introduction, and thank you for organizer and committees to inviting me. This is about some gene expressions in Keynote 522. I hate gene expressions, and I don't know who gave me this presentation, to be honest. But so this abstract is mainly theoretical. I don't think currently will have a clinical implications, but we know in the era of personalized therapy, so we know that certain populations with certain gene signatures, they might benefit more from certain kind of therapy, and probably in the futures we will have some clinical implications. And the other thing is that it's very luxurious. You will see they did DNA sequencing, the whole genome, RNA point mutations. I think still in many countries they don't have the luxury to do this NGS, and even here in UAE, some of the centers we don't have it. So it's about an exploratory biomarker analysis of the 522 keynote when they use pembro plus chemo versus placebo plus chemo in early stage triple negative breast cancers. This is the disclosure of the presenter, and this is the background that we know that keynote is placebo-controlled phase 3 trial. You know, when you use neoadjuvant and adjuvant immunotherapy, here we're talking about pembro, and these patients that are newly diagnosed, chemo-naive, immuno-naive, high-risk, early-stage triple negative, you're talking about T1C to N1, N2, and even 1 centimeter, and T2, T4, and 0 to 1. So this is how to look at, you know, progression-free survival, overall survival, and definitely the pathological complete response rate. And this is the endpoint of the study that, you know, the PCR event-free survival, overall survival, it was statistically significant, 64 versus 51% to the placebo arm, adding immunotherapy to chemotherapy, triple negative breast cancer in such a group of patients. And you have the event-free survival, 84 versus 76, 86, 81 overall survival. You see the p-value is significant. Here they'd like to collect certain patients to have, you know, to see for the potential association biomarker, who benefited more, who did not benefit. This is up to March 2021. So this, what are the biomarkers? They did a lot, so tumor mutation burden, BRCA, HRD mutation. So you can see they did the whole exome sequencing of tumor. They did an RNA sequencing. So the objective for this biomarker is to be pre-specified according to, and then they do the statistical analysis. So the key objective is to determine the associations between the PCR and the gene signatures, and to correlate also between event-free survival and overall survival. And they divide this gene signature into something called T-cell inflamed gene expression profiling, tumor mutation burden, and the non-T cells gene expression profiling, and to select out of these the TMBC molecular subtype, HRD status, HER2, P10 loss signatures. And you can see here, like, you know, that there was an association between the T cell gene expression signature with the PCR and event-free survival. So in terms of the biomarker tumor mutation burden, the T cells gene expression profiling in terms of PCR and event-free survival for the immuno arm. But however, for the placebo arm, it has the same in the T cell, but the tumor mutation burden was associated with a PCR more, but there was no event-free survival. What does this mean clinically? For us till now, nothing. Maybe in the future we will know more. And this is again the association between PCR event-free survival and the T cells gene expression profile subgroup. They, consider it like PDL1, less than one, more than one. I don't know, this is, less than first turtle. This is not the ninja turtle. So something like turtle in the gene profiling, and something is more than one. So if it is less than one, the hazard ratio is still 0.68, but if you look at the confidence interval at across one, it seems like with less signatures of the T cell gene profiling, adding immunotherapy does not have a statistical significant PCR and event-free survival, but if higher molecular expression, when the T cell gene expression is more than one, it seems that, you see the hazard ratio 0.54 and the confidence interval did not cross 1. So more T-cell gene expression profiling adding immunotherapy will promote having more PCR and event-free survival in such a group of patients. Again, for tumor mutation burden, it's very clear when you have high tumor mutation burden regarding event-free survival, you can see a huge separation of the curve. So patients who have a high tumor burden, adding pembrolizumab in neoadjuvant setting in such a group of patients triple negative produce better event-free survival. Here, as a classification, this certain gene profiling not related to T-cell gene expression profiling. Again, what are these? There are many sub-items like glycolases, hypoxia, make rice, RAS genes, proliferations index, angiogenesis index. And there is certain positivity and negativity for a certain factor. Like in PCR, it was positively associated with MDSC, it was positively associated with glycolysis, hypoxia. So when you have expression of these genes, you're inducing more hypoxia to the tissue, more cell death, more pathological complete response, but it's not all reflected in an event-free survival. You can see like only the proliferation index, but the other not. So it's mainly, like a clinical laboratory rather than a clinical index. What about HRD, tumor P10 loss, HER2 signature? But just reminder that we're talking about triple negative breast cancers, and there are subgroup, the genotype of triple negative, maybe up to 7 or 8 genotypes, which are sometimes are HER2 over amplified or even as a luminal A or B. So according to this triple negative molecular subtype of breast cancers, also adding immunotherapy doesn't look, in any of them like associated with the biomarker that we can select to know that this patient will have better PCR and event-free survival than other. Again, more clarifications by the curve, because you have the basal-like triple negative breast cancers, you have the immune activated, you have the immune suppressed, you have the luminal androgen, and you have the mesenchymal. And it looks like the one that subgroups that get the best benefit from adding pembro is the one with LAR, luminal androgen-like, where the hazard ratio is 0.48. So by PCR and event-free survival in HRD group, again, HRD positive, they get better benefit in terms of pathological complete response and event-free survival, hazard ratio 0.67, confidence interval did not cross 1. So in conclusion, that this exploratory analysis out of the Keynote 522, that there are several biomarkers, including the T-cell gene expression, were positive prognostic for PCR and or event-free survival, but were not predictive, to be honest. So this is a strict criteria to say we will use pembro here, we will not use pembro there. High tumor mutation burden was associated with improved event-free survival in the pembro plus chemo, not with the placebo plus chemo. Notably, there were relatively few patients with high tumor mutation burden. Again, you can make it a rule on this few patients, we don't know. Pembro plus chemo had efficacy advantage versus chemo alone is a subgroup defined by a variety of potential biomarker, sorry, that are the tumor mutation, the triple negative subtype, mainly the LAR, HRD status positive, they get more benefit, the non-T cells, proliferation index, angiogenesis index, and etc. I think this is the last slide. Thank you very much.
Thank you so much, Dr. Araf, beautifully presented. I think this is one of the, I picked it just to tease out that like we have not yet come to a conclusion where a specific biomarker that we can identify to decide on which patient actually we can put on pembro versus not. So right now it's a universal decision for most of the patients. Okay, any questions? Yes, Dr. Ran. Please go ahead. Can we get a mic for Dr. Ran? Yeah.
The standard regimen, the patient had quite a good response, but there was residual disease. Now, maybe studies like this will help for these patients. What should be the additional treatment after that? Normally, you have three options: pembro, you have capecitabine from the previous studies, and then probably olaparib. Like, what would be your opinion in this particular case? How would you go about? I mean, can we omit pembro, or should we continue with also the PARP inhibitor, or even capecitabine?
Absolutely. Dr. Arif.
So this question is not related to this presentation, but I will answer you. So we know from this gene signature study that patients who have HRD positivity, they got more benefit from adding immunotherapy in terms of pathological complete response and event-free survival. And we know from the Olympia trial that in BRCA-positive breast cancer patients, adding 1 year of olaparib will have better survival. But those patients were HER2-negative disease. So if you're talking here about triple-negative disease, if you have pembro achieving complete pathological response, now you have a discussions. If the patient achieve a pathological complete response, many of our colleagues, we sit and discuss together, do we need to continue pembro or not? Because nowadays it's very expensive, insurance, we have a limit, mandate, there is no mandate. In the majority of cases, when there is a chance to continue pembrolizumab, we continue pembrolizumab. In case of no pathological response, complete response, now there are the discussions whether to add capecitabine to pembrolizumab in the adjuvant setting, and I think there is no clear data, but many medical oncologists will add capecitabine in the case of non-pathological complete response. For me, in case of BRCA positive, if the patient is in pathological complete response and they have the luxurious to continue pembro, I will continue pembro, and I will add adjuvant olaparib later. Whether to combine, there are many analyses before of combining pembro plus olaparib. I don't think this will add more combination together. You can give it as an adjuvant setting later. But if the patient did not achieve pathological response, probably I will add capecitabine, finish the pembro, I'll add olaparib later. I don't know if Dr. Aida have another opinion.
Yeah, no, I mostly agree with you. So, in your case in particular, a patient with BRCA2 positive, I would continue pembro in the adjuvant setting. We know that even with residual disease, still we get some benefit from pembrolizumab in terms of event-free survival. But at the same time, I would definitely add PARP inhibitor. But whether later to add capecitabine or not, I wouldn't add most of the cases. So I would just do
Dr. Nahad, you like the answer or no? You don't look happy.
No.
Support her.
Okay.
Okay, but that's a challenging case that we witness in the clinic. So thank you so much. Allow for one more question? Yes, I saw Dr. Imad actually raised his hand before. So.
Just a comment, there is a safety data about the combination of pembro and olaparib in a metastatic setting. So it's safe to combine both the olaparib and the pembro. There is no safety data on combination of pembro and capecitabine. So this is my comment only, just to highlight this. But there is a trial that was in the metastatic setting for triple negative, combining pembro and PARP inhibitor.
Yes.
It's a very small, but it's a safety data.
Yeah, can I comment? But yeah, I'm not saying it's not safe. There is safety data, but there is no additional efficacy in the metastatic setting when you add olaparib to pembro. That's why it's not an FDA.
It was an exploratory, so definitely we will not be extrapolating, but however, it's expert opinion, according to international guidelines, expert opinion, to combine, if the patient is a BRCA positive patient, is to combine the pembro and the olaparib in those who didn't achieve pathological complete response. But there is no great consensus on adding of capecitabine and pembro. This is right. What I'm stating.
And even after completion a year of olaparib, pembro, there is no rule for capecitabine at that time based on the initial trial, the CREATE-X.
And secondly, what we are using in the Middle East, the capecitabine doses that we are using is not like the CreateX. So that's also...
That's totally right. I'm sometimes using in combination with radiotherapy, by the way, like the rectal cancer. You give capecitabine plus radio.
Thank you.
So your abstract is triggering more and more questions, which is very good. Dr. Hikmet, please.
I mean, just for the sake of time, thank you. It's a very nice talk. We at KHCC, I mean, cost-oriented. So what we do, if a patient achieves pathological CR on Pembro, we don't continue Pembro beyond the surgery. However, we give the patient the option, if they want to do it, to do it out of pocket, not on insurance. That's number one. Number two, if a patient failed to achieve pathological CR on Pembro, so the question is, why should we continue with a losing drug? And this is, well, when we switch patients based on CreateX, we put them in not on Pembro. So we don't continue Pembro if the patient failed to, we go to CreateX. So I guess all of us should be cost-oriented. The combination of drugs is toxic, costly, financial toxicity is an issue. Insurance won't pay for this. However, we always give the patient the option. If they want to pay out of pocket, they can do so, but not in publicly funded hospital.
Absolutely.
Like ours.
So thank you so much for this comment. We have to always look into
very small. I agree totally with your comment. Just to know, we can agree all that patient with triple negative who did not achieve pathological, this will do very bad in the future. This patient, they have the worst prognosis ever. The majority of them will relapse. So the idea of continuing Pembro and adding something like olaparib if they are BRCA or capecitabine, I think is just to augment their, potential response and survival rate. Thank you.
Thank you so much.
Now, my pleasure to introduce Dr. Ayman Abadi. He is a medical oncologist at Barjeel Hospital. He will talk about MammaPrint, Blueprint, predict pathological response for neoadjuvant.
Assalamu alaikum. Good morning, everyone. Thank you for the introduction. And on contrast to Dr. Arif, I don't hate molecular and I don't hate genetics. So I'm glad to be presenting this. So this is data from the FLEX trial in which MammaPrint and Blueprint were tested to predict pathologic response to neoadjuvant treatment in patients with hormone receptor positive, HER2 negative early stage breast cancer enrolled in this trial. So we know that pathologic complete response in patients with hormone receptor positive, HER2 negative early breast cancer receiving neoadjuvant chemotherapy is quite low. So in 2 previous studies, they showed MammaPrint risk of recurrence and Blueprint molecular profiling can predict pathologic complete response likelihood in hormone receptor positive, HER2 negative early breast cancer. So FLEX trial is a prospective longitudinal observational study that enrolling patients with early breast cancer with MammaPrint and Blueprint on their primary cancer. So this analysis evaluates MammaPrint and Blueprint as biomarkers for predicting pathologic response, which includes pathologic complete response and minimal residual cancer burden, and pathologic complete response alone in patients with hormone receptor positive, HER2 negative early breast cancer from the FLEX trial. So patients included in this analysis were enrolled in the FLEX trial. Eligible patients had hormone receptor positive, HER2 negative early breast cancer treated with neoadjuvant chemotherapy and had available data for testing pathologic complete response and residual cancer burden. Patients, according to MammaPrint, were divided into ultra-low, low, high risk 1 and high risk 2. These patients, according to Blueprint, were luminal type A, luminal type B, and basal type. Of course, we have in high risk 1 having luminal B and high risk 2 having luminal B type. So the study endpoints included pathologic responses, pathologic complete response, and minimal residual cancer burden. Difference in the clinical characteristics and responses were evaluated by the chi-square or two-sided proportional z-test. The association between MammaPrint, Blueprint, and pathologic response was tested using multivariate heuristic regression curves. and was adjusted for, and was adjusted for T-stage, nodal stage, grade, and chemotherapy regimen used. So this is a very crowded slide. By the way, this is a poster presentation. So these were just cut out of a poster. So we know there was a trend of patients having higher mama print values and higher blueprint values to be having a higher T stage, having more lymph node involvement, and having a high grade. So this is just an observation. Other differences were not statistically significant. So if we look at this curve, we see that the pathologic response, when plotted against the blueprint and mama print, we see that there is a significantly higher proportion of patients achieving pathologic complete response and minimal breast cancer burden when they have a high 2 mama print value, whether they are basal or luminal, in comparison to patients having low risk or luminal A or H1 score. So if we look at what was significant, we can see that there was a significant difference in the odds ratio for achieving a pathologic response in patients having a high 2 score versus high 1. This was statistically significant. Other values that are usually markers that are used by clinicians to determine if this patient gets any adjuvant treatment or not, such as tumor size, the presence of lymph node disease, or higher grade, were not statistically significant to cause a pathologic response. So even the type of chemotherapy that was used, whether these patients received the intensive AC plus minus platinum or these patients received the TC, there was not a statistically significant difference in the proportion of patients attaining pathologic response. Again, when we compare pathologic complete response rate among mama print regarding lymph node status, where it's, what I think most of clinicians use lymph node status to determine if this patient is eligible for neoadjuvant chemotherapy, we see there's no difference. Still the same values appear. We see more pathologic response in H2, regardless if it is lymph node positive or not, more in H2 luminal B and basal subtypes. So mama print classified as low risk H1 and H2, nearly 60% of patients were lymph node positive, higher stage, and grade cancer were significantly more likely to be mama print high. This was probably predicted. Most H1 tumors were luminal B, while 45% of H2 tumors were luminal B and 54% were basal. Patients with H2 tumors were generally treated with anthracycline plus minus platinum containing agents. Pathological responses rates were significantly higher in H2 basal and H2 luminal B, so all H2 as compared to H1 luminal B. Pathologic rates were mostly driven by pathologic complete responses, with fewer than 10% achieving residual cancer burden 1. There was no significant difference in pathologic response rates between node negative and node positive disease. Mama print high 2 was significantly associated with higher pathologic responses and pathologic complete responses in comparison to other scores. So menopausal status, T stage, nodal stage, higher grade, and even the chemotherapeutic regimen used was not significant enough to predict pathologic response or even pathologic complete response. So mama print and blueprint predict sensitivity to neoadjuvant chemotherapy in hormone receptor positive, HER2 negative early breast cancer. Patients with mama print H2 tumors, including luminal B and basal subtypes, are more likely to develop pathologic response or even pathologic complete response with neoadjuvant chemotherapy compared to low-risk H1 patients. These data suggest that mama print H2 identifies hormone receptor positive, HER2 negative cancers with higher sensitivity to neoadjuvant chemotherapy, which may enable downstaging and may improve overall outcomes. Treatment with an anthracycline did not independently predict pathologic complete response across subtypes. Prior studies have shown that anthracycline therapy increased pathologic response rates in mama print H2, but not H1 disease. This will be further analyzed in FLEX as more neoadjuvant chemotherapy patients are enrolled. Thank you.
Thank you, Dr.
In summary, I believe it was very clearly shown in the data that the usual markers we use as surrogate markers for patients to give neoadjuvant chemotherapy and predict response are not the best markers that we use. Maybe understanding better the molecular profile of this patient with early breast cancer is the best marker to understand which patient will need neoadjuvant and which patient will have a response with the neoadjuvant treatment.
Okay, Dr. Ayman, do you think you will use it in the clinic, membrane, to identify to whom you will give? And we know all of us, we are using Oncotype DX to decide on adjuvant chemo.
Well,
What about a new adjuvant?
I believe in the more recent years, it was been like a shift towards patients. Since we have CDK4/6, maybe that it's okay to have a patient with a lymph node disease. It's okay to go for upfront surgery. We already have a good adjuvant treatments. So it was always thought this way.
Yeah,
maybe,
but at the same time, we have studies showed that downstaging axilla with a new adjuvant, it's good.
Yes.
So how can we incorporate what you presented to what we are doing in the practice?
So I think today the whole discussion whether to go for neoadjuvant chemotherapy versus upfront surgery in patients with early breast cancer that are hormone receptor positive, HER2 negative is depending today on markers that in this study have shown to be non-predictive. So I think this might be a tool to choose which patient can benefit and can be enrolled in neoadjuvant chemotherapy.
Doctor? I was looking for you in the preview.
Ernest had his mic.
I did not start the presentation until Dr. Hassan is here.
I've noticed that, yeah.
Thank you. First of all, let's put it in context. This is ER positive. So we actually never use, these are predictors for prognosis, but not for response to chemotherapy. So I'm not sure why they put all of these. They are not predictive of response. They are predictive of they have bad disease, or I think the more prediction was more coming from Ki-67. I don't know if there was a Ki-67, maybe.
No, it's not that early.
One of the most important one for prediction of.
But they used grading, so
yeah,
they put grade 1, grade 2, grade 3.
Is, in the eye of the beholder, you know, it's not as accurate as Ki-67. Clearly, there is data on Ki-67 in ER positive that the higher you are, the more response you are going to have. Like Dr. Khair mentioned, you know, the CR rate is always low in ER positive. It's only in the range of 10 to 18% in the best scenario. Even if you take the high Ki-67, you may reach 20%. So our aim of down grading or down, you know, the disease is not to attain a CR, but at least to try to either minimize surgery if you end up with a good partial response, or at least staging the axilla may be beneficial as well. So I think you have to put it in context. This is not triple negative or HER2 positive, where you use the lymph node status and the size to determine the new adjuvant.
Yeah, but Dr. Hassan, how many patients with early breast cancer, let's say node positive, who are ER positive and HER2 negative, end up receiving neoadjuvant treatment, and then they end up with a non-pathologic complete response or with a high residual disease? So at this point, you might question yourself, why did I give neoadjuvant?
No, because you are going to give chemo anyway, right? So these patients, if they have node positive, especially if they are premenopausal, they are going to have chemotherapy. So whether you give them neo or post, surgery, it's the same results. I agree, but that's why I mentioned the benefit is going to be more in the surgical.
Dr. Hassan, I mean, the only benefit probably there is a proportion of luminal and HER2 enriched population. You can identify them by P53, and those the patient probably they benefit from the neoadjuvant.
That's what I'm saying.
Yeah, but I mean this is again translational study to see if this can direct you or may not.
If I may comment, actually this is in a way I disagree a little bit with you, if I may, because this study was like a step further on. I'm a little bit biased because this mama print, of course, is Dutch, and I worked with it. But the blueprint has lots of secrets hidden in it, which haven't been fully discovered. Actually, this study is a step up from the N-breast study, which was published by Woolworths in 2017 in the GCO, and also by Deitch, where they found that when patients were treated according to classical parameters based on immunohistochemistry, and then were afterwards stratified by a pre-treatment core needle biopsy that was only analyzed after treatment, that you could define subgroups that based on the molecular subtyping had a better pathologic complete response. And that gave rise to studies like this. And I do agree that molecular subtypes has its future. And what struck me and what still strikes me and puzzles me is that in average USA labs, luminal-like tumors are based on immunohistochemistry. Almost 1 out of 5 is actually triple negative because the hormone receptor pathway is intracellularly not fully developed. So actually you have the car with the headlights, but the headlights are not working. I mean, I only look at the headlights. So would you be willing, like sometimes you have these luminal bad guys that do very worse, would you then be willing to, as a start off, to do some kind of molecular subtypes against these specific patients to tailor better your chemotherapy?
Yeah, well, I hope this comes into practice soon, where we can better identify which patients need neoadjuvant versus patients that, from molecular profile, we know that these patients will not benefit. Then why just to give them neoadjuvant?
Excellent.
You are going to give them post,
For the
right?
sake
You're
of
going to give them
time.
adjuvant anyway.
Hassan, quick question.
Just a quick, actually, it's also a rebuttal to Dr. Hassan's point that MemmaPrint is not predictive of response to chemo, but we have Oncotype, which is predictive response to chemotherapy. So the genetic classifiers are not all in the same category also. So we could, this study didn't use Oncotype, but we have data from Oncotype.
Thank you so much. I think we'll move on to the next. Thank you so much, Dr. Amin. Amazing presentation. So we'll move on to the next speaker. I think Dr. Tarad doesn't need any introduction. My ex-colleague and dear friend, who is a consultant medical oncologist and expert in breast cancer at Tawam Hospital. So welcome, Dr. Tarad.
Assalamu alaikum. Thank you, Dr. Aida. So I will present the HER2-DX RBB2 mRNA score in first-line metastatic HER2-positive breast cancer treated according to the Cleopatra phase 3 study. This is a correlative analysis from the study. So as a background in first-line HER2-positive metastatic breast cancer, Cleopatra protocol is the standard of care. But we know novel therapy are emerging, and this underscoring the need for precise biomarkers to guide treatment decisions. So the HER2-DX RBB2 mRNA score is a quantitative assay with predicted cutoffs, low, medium, or high, which enables standardized stratification of tumors based on the expression of the RBB2 expression to guide the treatment. Just as a definition, or just as a background, the HER2-DX genomic as a test or assay is a test which uses or analyzes 27 genes, and it incorporates or integrates it with clinical characteristics of the tumor in terms of the tumor stage and the nodal status. And this will give us three key scores. One of them is to look at the prognosis, so this is the high risk score, or to predict who are the patients are having more potential for pathologic complete response, and this is the pathologic recurrence, and the mRNA score, which will give us who are the patients who might benefit better from the anti-HER2 therapy. So 2 prior real-world studies in HER2-positive metastatic breast cancer demonstrated that tumors with high HER2-DX RBB2 score are associated with better progression-free survival and overall survival following the THP and second-line TDM1 monotherapy or beyond, compared to those who are having a low score. And this analysis, the aim was to assess for the first time the HER2-DX RBB2 mRNA score ability to predict who are the long-term outcome in the Cleopatra study. So what was analyzed is the available formalin-fixed paraffin-embedded tumor RNA from the participants in the Cleopatra phase 3 study, and this was conducted, the assay itself was conducted at the Reveal Genomics Central Lab, and this is in Barcelona, Spain, and this is blinded from clinical data. So the HER2-DX RBB2 score evaluated both as a continuous variable, so from 1 to 99, and as a predefined groups, low, medium, and high. And what they took cutoffs. 1 to 32 is low, 33 to 50 is medium, and more than 50 it was high score. And this was correlated with the overall response, PFS, and overall survival. Logistic regression and proportional hazards models were used, and the significance level for all statistical analysis was set at a two-sided alpha of 0.05. So out of the more than 400 patients in the Cleopatra study, they took 221 patients. They succeeded to get the FFPE tumor sample, and with a success rate of around 97%. And they did the expression and succeeded to divide the tumors or the patients in this case into three categories. The high, which represented around 77% of the patients, 78, medium, which is around 9% of the cases, and low, which is around 13% of the cases. These patients had an overall response of 78%, median PFS 18.7, and mean overall survival of 60 months. These are the baseline characteristics of the patient, of this group of patients selected as compared to the whole group of the Cleopatra, and we can see from this study, I will not go through them one by one, but briefly, these are similar characteristics on both groups of patients, the selected and the initial group of patients from the Cleopatra study. Here, this is the graph to show the correlation between the HER2-DX RBB score and the PFS, and clearly patients who have the high score got the best median of PFS of 20.3 months. The medium had 18.7, so close, whereas those who are having low score had 10.4 months PFS. So we see, this is just to confirm what was noted before, that those who are having higher score are doing better with the anti-HER2 therapy. Same applies also for the overall survival, where we see patients with high score having median overall survival of 72 months, whereas those who are having low score have a median overall survival of 40 months. In terms of overall response, again, patients who are having the intermediate and the higher score as compared to patients who are having low score, they have a higher overall response rate. So these results, the Cleopatra DX subpopulation represented 53% of the original trial cohort, so we're talking about 214 out of 402 patients. The baseline characteristics and survival outcomes of this cohort were similar to the original, and the HER2-DX RBB2 score analyzed as a continuous variable demonstrated an association with PFS and OS after adjusting for the IHC status +1, +2, +3, and this was associated with PFS and overall survival. Patients with high score showed superior median PFS compared to those with low score. Again, patients with high score showed better overall survival compared to those with lower score, and the HER2-DX RBB score as a continuous variable and as group categories was not associated with overall response rate. So the conclusion, the HER2-DX RBB2 mRNA score, both as a continuous measure and within pre-specified group categories, is strongly associated with long-term survival outcomes in HER2-positive metastatic breast cancer treated with first-line THP. Notably, the RBB2 low category identified by HER2-DX had the poorest PFS and overall survival. Thank you.
Thank you so much, Dr. Tarad. I think we are getting more and more data, exploratory data from the Cleopatra trial, but it remains the first-line standard of care for all of the patients with HER2-positive metastatic breast cancer. Any questions from the audience? Yes, Dr. Hassan.
Hassan, no Hassan, less questions. Was Hassan, bank of questions. Yes, Hassan.
Okay, thank you. So obviously we want to see how this is going to apply to our day-to-day practice. Obviously right now, that's the only option we have. Did they do correlative molecular testing on these patients to see if those with low score maybe had other mutation like PI3K? Because we know the group who had PI3K had less responsive to anti-HER2 in general.
No, it was not done. The aim was just to see who is the group of patients who might benefit more from the anti-HER2 therapy. The aim was not to say, let's say, that we will not use anti-HER2 therapy in a specific group, but just to see who is a group of patients who might benefit more. When we talk about novel therapies, we know that maybe soon we will not be using THP as the first line. Maybe we will shift to trastuzumab deruxtecan, for example.
That was my next
So in this case, as if we are escalating. So the question here, which group of patients we can de-escalate and which group of patients we can escalate the treatment.
And
not to say which group of patients will not get the anti-HER2
My
therapy.
next question was based on the Destiny Breast ongoing, whether they are going to look at that to see if that's where maybe the most differences we are going to see in those with the lower HER2-DX score in the DB09.
Dr. Nahad.
I'm really surprised a little bit by the poster and how the data is presented, not by you, by the others.
I am not the main author.
I'm not supporting Hassan. Actually, the HER2-DX literature is very profound and rich, and these people really published at least 8 papers in Tier 1 journals. And nothing in Tier 2. It is very, very profound data. And really it is based on scoring of overall response and scoring of recurrence. And I do not see anything in this data analysis there, number one. Number two, in the low score, the complete remission rate we're talking is less than 20%. Here, it is, I think, progression-free survival is 50%. Does not go very well with the reported literature at different levels. So when looking at this poster, unfortunately, I don't feel like I learned anything. If you review the literature on HER2-DX, you see there is disconnect. Although it is a positive data, I'm sure it's going to be published in a very good place. With my respect to all the collaborators, I know many of them, they are really great people, but I do not know what to make out of it, except, as you said, 10-minute timeline.
Yeah. I mean, this is the score here. I mean, in the test itself, so they can look into the group of patients, and this is most of the data initially came from the early breast cancer rather than the metastatic. Here we are talking about the metastatic breast cancer. So when we talk about the, let's say, long-term prognosis, or let's say talk about the pathologic complete response, it will be more on the side of the early. Here, if we are talking about the mRNA score, the HER2-DX RBB2, I think the most of the benefit will be maybe in the future. As I said, if we have, let's say, in the future, the HER2, the trastuzumab deruxtecan, the Destiny-09 positive, if it will be positive, and most likely it will be positive. So imagine when we give, let's say, our patients THP, we never continue the chemotherapy until progression because of the neurologic toxicity limitations. This same thing will apply when we talk about the, for example, the trastuzumab deruxtecan, where again, if we continue, keep going, still there is element of chemotherapy within that compound. There is toxicity, whether in terms of toxicity on the body or financial toxicity. So maybe in that case, This can be helpful in terms of maybe some patients at certain point in time, if we give the trastuzumab deruxtecan and we know that they have, let's say, lower score, if we choose to take that one, at some point in time we may discontinue and maintain patients on HP rather than TDXD, and in this case we avoid both the toxicity and the financial toxicity as well, both. So I think this might be helpful, but whether this is applicable at the moment or not, I don't see it applicable at the moment.
Thank you.
Yeah, but the poster did not reflect your point of view.
No, it did not.
Which I agree
the
with
poster itself was just to show if there is a group of patients benefit more or less, according to the score itself.
But they did not address the score. They did not address the original scoring system. And there is a publication in metastatic disease that addressed the same issue. Well, you know, I know it's not fair to put you in this spot. You were not there to analyze the data, but I'm projecting from what I know about HER2-DX.
Yeah. Okay.
And thank you, but for the time being, still this is a positive trial, but it will not change any in our practice. Now it's my pleasure to introduce my colleague, Dr. Hassan Jafar. He's a medical oncologist at Barjeel Hospital. He's a senior medical oncologist. He will present the triple negative DX genomic test.
Thank you, Dr. Khair, for this kind introduction. Good morning, dear colleagues and friends. Thank you all for having me here today. Again, all the presentation in this session is just a translational study, just to understand more about the biomarker and the clinical implication. Probably it will be happening in future. So none of these are practice changing. So my abstract is again on we know that Oncotype DX and HER2 DX and now TNBC DX is a genomic profiling to predict the aggressiveness of the tumor, and then this study is just to see if this TILs can add to that information more in patient having neoadjuvant chemotherapy. So we know that the background of this, that TILs can be a predictor to respond to immunotherapy, and we know that the TNBC-DX, it's a novel 15 gene which integrated immune, proliferation, tumor size, and nodal status markers to predict the response to neoadjuvant chemotherapy and the prognosis of those patients. So this has been done in a prospective study. 280 patients received carboplatin docetaxel of 6 cycles as neoadjuvant chemotherapy. And in that trial, the general PCR was 48.6%. And there was another study, 108 patients with docetaxel carboplatin 6 cycles plus pembrolizumab, and the overall PCR was 58%. Now, if we know that the data which led to the TNBC DX, first, initially, they assess through 3 clinical trials, mainly the signature for those, and they select 10 gene of immunosignatures and 4 gene of proliferation signature, tumor size incorporated and nodal status, and prospectively, they study it in ADAPT and in the MMMG trial, that's showing here that those with high risk, they have a higher PCR, but if you look into the disease, distant disease-free survival and the overall survival were more in favor with those with low risk of TNBC-DX. This is the study result, and if you take the multivariate analysis, we see that those, if you split the TILs infiltration, those who are less than 5%, 5 to 29%, and more than 30%, we see that those, the higher infiltration, the higher the odd ratio and the response to treatment, again, the same for those with TDNBC. And also we show it in the multivariate analysis that this is significant. If we look into the response rate, we see that on your left side, those patients, they received the chemotherapy, docetaxel, carboplatin alone, while on the right side, you see those with pembrolizumab. And if we look for those, if you take the surrogate of the score of TNBC-DX plus the high infiltration, we see that we reach complete PCR of almost 91%, while the other markers is almost similar. And this can probably predict those who are the most benefit from immunotherapy versus others if we take these markers. And this probably, it should be translated into a different conducting clinical trials and to probably categorize those patients according to the risk category and the response to treatment, and changing the outcome whether to have a low complete pathological response by selecting the biological markers to high selection and high complete pathological response. So we know that the Oncotype DX is the most clinically used. We know that the HER2 DX and the TNBC, it's still exploring to find probably the exact positioning of these biomarker in order to select it. And this is probably the job of the clinical trials, how prospectively we can study these agents to select our patient for that. So the conclusion of the presenters that immune signature TNBC DX are more attractive for integration into the clinical in single immune biomarkers, in his opinion, and strategy-based clinical trials combined with biomarker should be designed to optimize patient care. Thank you very much.
Thank you. Any question from the audience?
Oh, horrible.
I saw some. I think it's great to have these like biomarker testings or like the predictive testing, but do you see any future of it like coming to practice?
We've been hearing about TILs. We have been hearing about these biomarkers for long. If you don't have exact, because again, those patients, the other patient, they may benefit from the treatment. We need a biomarker to select who will give immunotherapy, and we are giving very expensive medication for all the comers. So we are trying to identify what is probably the exact positioning of that immunotherapy. We know that around 20%, 25% of those patients, they benefit from adding immunotherapy, not all. So how we do that, and these are studies just to explore this. Is it the time to apply it in clinical practice? I don't think so. We still give it for everyone, but we know that those patients, if I have limited amount of money, probably I give it to those patients. But again, the test is expensive on the other side.
Excellent. Thank you so much. And
that we are offered treating something. So if we can de-escalate, it would be great. 5 minutes of break.
no, now we're going to move on to our sponsored session, Satellite Symposium by Novartis. Is going to be led by Dr. Imad Dawood, who's a consultant medical oncologist at Tawam Hospital and a dear friend. Please welcome Dr. Imad.
Assalamu alaikum. Good morning, everyone. First of all, I would like to thank Dr. Aida for a lovely introduction, and thanks for the Emirates Oncology Society for giving me this opportunity, and congratulations for the Best of San Antonio. So this is the, we can say like Satellite Symposium, small workshop for the breast cancer, and I'll be honored to be joined by two eminent speakers for our Satellite Symposium. So I would like to present the first speaker, Dr. Basit Jallad, who is a consultant medical oncologist in Cleveland Clinic in Abu Dhabi, who's going to talk about the expanding evidence for CDK4/6 inhibitor in the ER-positive, HER2-negative breast cancer from clinical trials to the clinical practice. So, the other one? It's okay. So you're mixing. It's okay. So you can see. There you go. I'm going to be sitting here. So it's time to bring the second speaker. Who's sitting calm. Dr. Said Ravi, who is going to talk about the expanding the evidence of CDK4/6 inhibitor in...
I don't want to steal your thunder.
Yeah. So Said Ravi, he's a consultant medical oncologist, Mediclinic. And
almost as tall as him.
Yes, yes.
All right, thank you, thank you. Thank you, everybody. Good morning, and thank you very much indeed, Dr. Aida, for the invitation, and also to Novartis for sponsoring this meeting. Really, it is very important to define the risk of recurrence of the disease, especially for hormone receptor positive breast cancer. And we all struggle to find a model really to accurately, as accurate as possible, to risk stratify this group of patients, because we really want to escalate the treatment for the ones that are high risk, de-escalate the ones that are low risk. So basically these patients, they have a different variety of recurrences. We know that about half of these patients, they have early recurrences, as opposed to the risk is going to linger around for much longer for another half of these patients. So a lot of these patients, they will have a distant metastatic disease, which is unfortunately currently incurable. So this was a presentation that was done at San Antonio by Paolo Tartinio. Basically what they did is that they looked at real-world data on Flatiron, which is a US patient's health record system. And they identified a patient that they would be eligible as eligibility criteria defined by Monarch E and the Natalie clinical trial. So let's have a look at it. So again, like I said, it is a Flatiron database real-world data set. They looked at the patient between stage 1 and stage 3, hormone receptor positive, HER2 negative, early breast cancer, eligibility criteria met for Monarch E or Natalie clinical trial. The endpoint were recurrence-free survival, a distant recurrence-free survival, and overall survival. So the recurrence-free survival defined as the first invasive ipsilateral disease, invasive local regional disease recurrence, distant recurrence, or death from any cause. Okay. I don't know whether we can move on to the next one. Somehow it is not working. Okay, there we go. Thank you. So just as a reminder, the Natalie, obviously we know that if you have a stage 3, you would be eligible to take part. If you're a stage 2B, you are eligible to take part. Stage 2A is eligible if you have a node-positive disease. If you are a node-negative, grade 2, grade 3, again, you will be eligible. If you are a grade 2, you have to have one of the high-risk features, such as a high Ki-67 or high genomic score, basically as per Oncotype DX, Prosigna, MammaPrint, or EndoPredict. As opposed to that, Monarchy put actually more high-risk patients. So these are patients who had more than 4 lymph nodes, or if you have 1 to 3 lymph nodes, you have to have a grade 3 or more than 5 centimeters in size of the tumor. There was a cohort 2 based on Ki-67, as we all know about that one as well. So essentially, after selecting those patients, they ended up with 7,481 patients who would be eligible as per Monarch and the Natalie clinical trial. 39% of these patients, they were Natalie eligible, 15.5% they are Monarch E eligible. So again, you know, we do expect this because Natalie put more patients who were kind of as seen by Monarch E as a lower risk patient. So the broadest spectrum of patients as per Natalie clinical trials. So the characteristics, they are fairly the same between the two. The only difference that you can see here is the chemotherapy, for instance. We had more patients who were on Monarch E. They received more chemotherapy as opposed to Natalie clinical trial. Again, this is expected because, you know, these are supposed to be more high-risk patients. Look at the nodal disease, it is different. Again, you know, it is expected because the eligibility criteria, they are different as well. 55.1 month of follow-up for these patients as well. Now let's have a look at the risk of recurrence, and that is a comparison between the two groups. You see that there are more patients basically they are eligible for Natalie, as I said. But look at the risk of recurrence, 18 and 18.6%, 5 years risk, the recurrence-free survival for for basically NATALEE clinical trials. So patients who are on NATALEE, they are at risk of recurrence of the disease at 5 years. Around 18.6% of these patients, they are at risk of recurrence of the disease. When you look at the 5 years distant recurrence-free survival, again, nearly 17% of patients on NATALEE clinical trial, they are at a higher risk of the disease. And at 5 years, unfortunately, 10% of these patients, they will die as a result of disease progression. So looking at, separating this one based on the stage, you can see obviously we did not have any patient on stage 1 on NATALEE clinical trial. On Monarchy, we had patient on micrometastatic disease enrolled, but looking at the stage 2, which is highlighted here with the red square here, you can see that the patient at 5 years with a stage 2 disease, around nearly 13% of these patients, they had a recurrence of the disease. Around 11.3% of these patients, they had distant metastases, and 7% of these patients, they died as a result of disease progression as well. So even stage 2 disease, they have a significant amount of progression of the disease. And now let's look at the nodal status, because we feel that patients who have node-negative disease, they're probably lower risk as opposed to the node-positive disease. Let's examine whether this is true. You see that the columns that are marked by red square, these are again patient node-negative disease on NATALEE. Even the node-negative one, around 13.6% of these patients, they had a recurrence of disease within 5 years. 12.6% of these patients, they had distant metastatic disease, and again, 7% of these patients died as a result of the disease progression as well. So again, you see that the node-negative disease, as it is generally perceived to be low risk, they are not so low risk. They have actually higher risk of recurrence of the disease as well. So what about prior chemotherapies? Again, there are some differences, as I said, because there are more patients basically on these two groups, and you see that there is some similarities between these two groups of patients as well. So in conclusion, they said that although that all these patients, they received a standard of care treatment, which is obviously endocrine therapy, even the node-negative patient, a NATALEE eligible patient on Monarchy, they have a relatively high incidence of distant disease recurrence within 5 years. Actually, distant recurrence-free survival between NATALEE and Monarch eligible patients, 83.1% for NATALEE, 74% for Monarch E. There was two more data presented, and then one is obviously the risk of recurrence based on the real-world database. One is based on, again, Flatiron database in the US, and another one, two centers, one Tennessee Oncology and the other one MSKCC in the US. We're going to review both as well. This is one 7,564 patients in Flatiron, and these are the NATALEE eligible patients as per node-negative patients, high-risk criteria. So when you look at the node-negative high risk, you can see that, again, at 3 years, 5 years, 7 years, these patients, they have considerable amount of recurrence of the disease, both in terms of the overall recurrence and also the distant recurrence of the disease. These patients, they are at higher risk, and they are actually very similar to the node-positive patient as well. So, there is very much similarity between node-negative high-risk patient and N1 patient. So this highlights the importance of really paying attention to this group of high-risk patients as well in terms. So when you look at the overall and distant risk of recurrence, again, you will see that it increases with the nodal status, obviously, but again, between the N0 high risk and the N1 disease, there is quite a lot of overlap between this group of patients. So N0 high risk patient, they do actually behave like a N1 disease. The next one is the study by Tennessee Oncology and MSKCC. Again, they looked at around 992 patients, and then highlighted in red square, again, you can see that patients who are node negative, natally eligible patients, and node 1 or N1 disease, there is quite a lot of similarity in terms of the risk of recurrence of the disease, even a long-term disease recurrence as well. So by that, thank you very much. So I think, we highlight the patient that they have a node negative high-risk criteria. They do behave actually like N1 disease, and it is very important to pay attention to that. Thank you.
Thank you, Dr. Saeed. So, Dr. Basil, who going to share any cases with us?
Thank you, Dr. Saeed, for setting the stage for better understanding of how to approach patients with, though look like less risk, but they are high risk N0 disease. And we should be also treating them kind of similar to the N1 disease, and could be even better even some N1 disease with low risks could be not even needing the chemotherapy as we do in the postmenopausal diseases, postmenopausal population. So this is very important, understanding the bimodal distribution of we should be less deceived by the HR positive breast cancer, our understanding that they are in a better prognosis compared to triple negatives and HER2 positive. This could be true in the short term, but bimodal distribution and increased risk of recurrence, even up to 20 years, is an important understanding to know how to do, what to do in the beginning, knowing that there is a carryover effect for the CDK4/6 inhibitor, and that is one way of understanding what we do in the beginning will set the stage what we do later, and could be also a good opportunity for improving our endocrine agent, like we're doing with the Cambria 2 trial, for example, which Cleveland is a part of. So I will be discussing two cases. Yes, this is a sponsored presentation from Novartis. The case that they first presented is patient with HR positive, HER2 negative early breast cancer, female, Asian, 50 years of age, and premenopausal, and she has a good active lifestyle. Unfortunately, she was diagnosed with HR positive, HER2 negative breast cancer. This is the characteristic of the patient, being PT2, about 4 centimeter size of a tumor. After undergoing surgery, she was found to have PN0, grade 3, KI 67, 17%, and with a recurrence score of 10%. So she ended up being an AGCC stage of 2A. So I'm going to start with you, Dr. Imad. So how does this patient fit into the phase 3 CDK4/6 inhibitor clinical trial, from your opinion?
I think it's fitting the criteria of the NATALEE trial. So definitely she doesn't need chemotherapy. So we will have to discuss with the patient the role of adjuvant endocrine therapy, hormonal therapy plus CDK4/6 inhibitor as per the NATALEE trial.
And this is how Dr. Imad mentioned the point of where it fits NATALEE criteria. So in patient with stage 2As, though they are stage 2s, but if patients are high grade or high KI 67 or high genomic risk, they can go ahead with using of CDK4/6 inhibitor, in this case ribociclib. And again, we are going to emphasize.
Can I have a question?
Yes, go ahead.
So the risk score of 10, right?
Yeah.
So what is the risk of recurrence in 5 or 10 years?
Yeah, so the risk is, in this case, is very low, definitely, based on the understanding of Taylor-X studies. But we have it also in a different study that shows that they are in a high risk compared to the real-world data that we are showing here. So maybe there's more than, that's why we're more and more. Go ahead.
Those without Oncotype DX, right? The real-world data.
the real-world data did not define if they are high, based on the Oncotype DX testing. It did not define it. So we're not sure yet. But we have that more and more evidence that even if we're talking about N0 disease, that their risk of recurrence could be close to the patients with N1 disease, and they could be behaving like a stage 3. So we don't know yet, but we have a data that is positive for a patient with just being a high grade, that they could benefit from that treatment based on what we are going to show here. Also, there's maybe a slide later that I can show that, not just the intent to treat population, but even the N0 based on the ESMO presentation, that even those patients are trending toward positivity toward, and just being an N0, you can use CDK4/6 inhibitors. So at least you can consider that, or you can discuss this with your patient. If it was my case, like in Dr. Ahmad's case, probably I will definitely recommend to be on that treatment. Because the other thing is, not TAILOR-X, maybe it's up to 9-year, 10-year data, but we need to even look at the 20-year, okay, to make sure that those patients that we're treating now are not recurring even 20 years later. Yes, go ahead.
Can I, thanks, Pastor, thanks, Ahmad. The question is, what you will leave for this patient when she will progress or have a recurrence in 2 years or 5 years or 10 years? I mean, we now in the morning talking about the NATALEE trial, but we certainly can be sitting in the afternoon here talking about abemaciclib, and this patient does not fulfill the criteria for abemaciclib. I guess today we have all to be cost-conscious conscious and talking about strategy, not a drug. I mean, I would leave the CDK4/6 inhibitor in this case when the patient to progress later or relapse or something. But definitely I will choose a subset of patients that will avoid to add a financial toxicity to the treatment. If you have to put your money, I mean, I'll put it the highest risk possible. I would leave those patients, at least they are not eligible for abemaciclib and not to be also eligible for the NATALEE trial. I mean, this is the personal opinion based on financial toxicity issues that we have to be cost conscious too. But I'm not sure that everybody would agree on this, but this is really my own approach.
No, I totally agree. I think when we say this is not high risk enough to give chemotherapy, I'm not sure you can join all N0 in the same bucket as you're showing from the NATALEE. These are thousands of patients. So I don't know if only one factor, like you mentioned grade 3, but the Ki-67 is 17%. The Oncotype score is very low. I mean, for that one case, you cannot say the risk of recurrence is for 14%. These are N0 altogether, lumped together. So I think it's case by case. I totally agree. There is financial as well as medical. I mean, some patient can have serious side effects even at the reduced dose. So I think we have to be careful, as Dr. Abdulrazak mentioned, not to be driven by a drug-related approach rather than what's best for our patients.
The issue is that, well, the inclusion criteria was either, right? You have grade 3 or. They didn't say ands. So one criteria fit from their end. However, knowing that others could, like SAWASH, like others could be a positive or a lower risk, could this mean that it could cancel what we have found as a grade 3? What do you think, Dr. Ahmad?
I think we are mixing between the high risk of if we need the chemotherapy, which I agree that she doesn't need any chemotherapy for these patients. But for grade 3 patients with perimenopause at age of 50, we know that those patients with hormone receptor positive, when they recur, they get very late. And the data that we have, that at 20 years of follow-up, there is almost 32% of the patient, they recur. Augmenting the endocrine therapy in the adjuvant setting to delay the recurrence. If there is a financial issues whatsoever, if I have a restriction because of finance, I will not use any of these expensive medication, but you have to discuss with the patients because it's her right. A grade 3 disease with a premenopause, hormonal therapy is the most important treatment for her. To give CDK4/6 inhibitor also to decrease the recurrence is very important. And we have data, we have phase 3 trials showing this benefit, this patient, they could benefit from the decreasing the recurrence event-free survival for her.
One last thing is, Imad, do you know how many patients you need to treat with CDK4/6 inhibitor, node negative, grade 3 to prevent the recurrence?
Well,
I can attempt to answer that one. So I guess, you know, a lot of the comments that you guys are saying, they are very true indeed. One thing that, however, is that if you look, is that we have the risk of the recurrence of this disease, as we showed, is lingering around for a very long period of time. And a lot of these patients, they're going to be hit by the recurrence of the disease and eventually dying from this disease. So we do agree. I mean, there is currently no biomarker to select for who is going to be, in fact, at the higher risk of the disease. All we know is that around 18% of these patients, at some point, they will come back despite having a negative lymph node. So certainly there is a biology that needs to be addressed. I think, you know, it is best to find this. But, you know, I guess, you know, to just come to say that this patient is not eligible for chemotherapy, therefore is not also eligible for CDK4/6, may not be the right way of doing it. Because, you know, these things, they are actually addressing different things. You know, cytotoxic chemotherapy as opposed to CDK4/6 inhibitor and endocrine therapy, they are addressing different part of the recurrence of disease mechanism. So I think, you know, I am not, Dr. Hassan, buying that kind of thing that because the patient is not eligible for...
There is also risk with the oncotype DX of 10. We're not just talking about, I mentioned chemo as an example, not to give chemo, but at the same time, what the score will tell you is that the risk of recurrence is very low. That's why chemotherapy is not affecting that risk, because it's already less than 10%. We have the Taylor X, a huge study, clearly showed even in that kind of patient with an oncotype of 10, the risk of recurrence is much lower than somebody who has other high features. So all I'm saying is it's a case-by-case discussion, and you cannot take it and move to all patients. Okay, you need to be on, that's all I'm saying.
There is no discussion that we need to better risk stratify these patients.
Correct. And I think I can go to the next patient, and then if we have the time.
There is 2 comments.
Yeah, I know, for the sake of time, I just be, I
it's your symposium, so
yeah.
You can go ahead as much as you want.
I think this is a very, I'm glad actually you presented this case because it's something relevant to our practice, and we get these patients. I was surprised like the patient had grade 3, because most of the time with this characteristic it's either going to be grade 1 or grade 2. So I may go back to the pathologist and try to verify
and better understanding.
The other thing is that also in this particular patient, yes, the risk, the cure rate is very high and the risk of recurrence is very low. So I'm worried in this, and I agree with my colleagues 100%, like I would think twice before I add CDK4/6 inhibitors with this patient. But my worry is that we don't even have an overall survival benefit. So for this particular patient, could delay recurrence as opposed actually to adding overall survival benefit. So
I'm not sure when we're going to have that, and we are now talking about a subset of patients, and we have to think about intent to treat population. I'm not sure how much we have a subset of only grade 3 of the N0s, unless Novartis team later can provide us these data, but we go with what we have. I don't think we should hide this data for our patient. It's at least it's a point of discussion with our patients if they want to go through it, knowing that there's also some morbidity out of it. So it's not like walk in the park. You know, there's a 3-year commitment there, but if they want to cure, they don't want to wait until they recur to take the CDK4/6 inhibitor, and then we're talking about more control of a disease rather than curative, then it's their right to understand and if they want to commit on those treatments. Yes,
Professor Nadbray.
Yeah. I have a few comments about this. First of all, this kind of analysis does not really fit the definition of real-world data. Usually, real-world data helps when identifying a subgroup of patients that you cannot find on ethnic or age or things like this. And number 2, this is information presented here was not included in the original data. with the understanding that Natalie was based only on 26% of patients analyzed. So still pretty premature. It could hold very well, but it is a little bit premature here. And I take this data as a hypothesis generating data that need to be addressed and not ready to be implemented in a clinical practice. And for those who would like this idea and do this, where do you put it against soft trial, where you do LHRH agonist and hormonal therapy alone? By doing this, we may not address the financial toxicity, but as Dr. Hikmat said, you may need the CDK4/6 inhibitor when it was properly indicated.
Correct. And that's like the idea of Cambria 2 trials is just enhancing. So they have two arms of it. One is with a CDK4/6 and one without, like those cases where you just not give CDK, you just enhance the endocrine agent. So maybe enhancing the endocrine agent by itself could suffice. And that's why we need more of those studies where you just, switch from, let's say, AI to a SERD. Maybe that would suffice and would give us still, a better recurrence rate, yet not putting the patient through dual endocrine therapy. So time will tell, I guess. So for this next case, I think we have more understanding that this patient is a high risk. She's 50 years old, HR positive, HER2 negative, T2, no, this, still we are in the first case, sorry. Okay, I'm just for the sake of time, I need to go to the next understanding. So this is the same case, but I've made it a node positive. So Dr. Saeed, what evidence currently supports management of this patient if she had a node positive, HR positive, HER2 negative early breast cancer? Would that change your approach? Would it make it more like a recommendation than consideration? Would it change the agent that you would be using?
Well, I mean, obviously, this patient is a more high-risk patient. I don't know how many lymph nodes, but anyway, she is at higher risk of recurrence of the disease, given that she is premenopausal, perimenopausal, and node-positive patient. Certainly, this patient, based on the node positivity, we may even choose to give chemotherapy, although some people may argue at the age of 50 being perimenopausal, maybe ovarian function on its own would be sufficient for this patient as opposed to giving chemotherapy. Nonetheless, I think, in the current sensitivity kind of portion of this for the adjuvant part of it, certainly I think this patient will benefit more from having another partner to the endocrine therapy, such as CDK4/6 inhibitor, given the recurrence score, which is higher, it's 27, and also the node positivity as well.
Okay. Yes, sounds good. So in this case, we've noticed that this patient would fit either, so we can go with either agent in this matter. I'm going to, and this shows that the intent to treat population in both studies, NATALA and Monarch-E, shows a carryover effect and an improved and invasive disease-free survivals for patients with and positive disease. So I'm going to go ahead. Okay, so we talked about which CDK4/6 inhibitor we will choose. Now, if you have the ability to use either, okay, would you, Dr. Imad, would you choose either CDK4/6 inhibitor based on safety and tolerability profile? What drives you to use one agent than the other now that we have both FDA approved? Now we can talk freely about that.
Efficacy-wise, both are effective. The difference in the safety profile, and this is, I will leave it to the patient herself. So I will discuss each drug, what is the safety profile, the duration of the treatment, and patient choosing between the two drugs. Yeah.
Dr. Saeed,
efficacy-wise, for me, I'm okay.
And same
How you're
here,
approaching it now when both agents are approved, are indicated in one case?
Same here. I guess, there are some people who say that we have a little bit longer follow-up data for Monarch-E as opposed to Natalie. Nonetheless, I think, we have shown that both of these agents, whether in the metastatic or early, actually they are doing more or less the same. So I would be happy to offer both of these things. Again, some tolerability issues, they come into play. Some people, they are very much troubled by the GI toxicity, in which case maybe ribociclib would be a better choice.
So I will show a couple of slides, and that's my last few slides here, about the adverse events in the NATALY trial. Basically, the most reason for continuation, and the continuation was about 19.7% because of adverse events associated discontinuation, and which about like 30+% for all kinds of reasons. But for the adverse events here, mostly it was about related to neutropenia. And I want to mention here that out of those 19.7%, 14% were discontinued without prior dose reduction. Usually, there is a one level down of using the ribociclib as per in the early stage setting. So if we're using 400, you can go down to 200 before you discontinue. Those patients were discontinued even before trying the dose reduction. And so we need to keep this in mind, because if we do this approach appropriately, not based on very strict protocols here, if patients have, and this is important for our population, and patients who have maybe a preset borderline neutropenia, and their neutropenia have continued for more than 28 days, they just discontinue the medicines. And we here in a population who have benign ethnic neutropenias, we have to be very careful about using just the neutropenia per se to not give this treatment its chance. So 14% discontinued without prior dose reduction, but 6% did it with as expected way. And this is similar to the adverse events percentage in the monarch E, which was about 18.5% for all kinds of adverse events. Out of them, 5% was for the diarrhea. And when we put both together, different safety profiles, after all, similar numbers of discontinuation because of adverse events. So we can show our patients this data fairly, and then they can decide which one they would rather have than the other. Okay. How much time we still have? I mean, I want to give a chance to go over another case, unless we don't have the time. Do we have?
No time, but
okay. Let me just go through what's the idea behind the second case. It is another case of 42 PT2 PN0 with a high Ki67 being premenopausal. I mean, maybe we could have had some discussion about how do you start your endocrine agent first, and then how then you add on or enroll your CDK4/6 inhibitors. Some people start with the OFS, or they can combine both at the same time, OFS and the AI, and then they add on the CDK4/6 inhibitor, or you may do all three together at the same time. You can pick and choose. In NCCN, they talk about having the appropriate estrogen suppression before you add on the endocrine agent. So you start with OFS, and then so you can do that with either. This case, I think, is also eligible to get either agents. Some patients who are N1 still not eligible for the monarch E, but they are in the NATALY. So, I mean, if you are data-driven, you have to be careful about those cases. The last question is just, would you still, with the patient, just based on the Ki67 being high, and that would be my last question, just being in a Ki67 high, and not fitting the monarch E data, but they are N1 disease, would you consider abemaciclib? Based on the cohort 2 data. Okay, in the beginning they were talking about approval for that, and then they withdrew the approvals. But still, some experts like Hope Rugo and others, when there was a discussion about that in the ASCO, that they would still consider that. But at that time, FDA wasn't approving ribociclib. But now we do have an agent that can be used in this matter without being off trial. Okay, that's that. Thank you very much.
Can I make...
Dr. Enes, you're waiting for a long time. You have a question, yeah, please.
Can I make a small remark based on the decision to use CDK4 and 6 inhibitors based on the nose positivity from a surgical perspective? It was nicely presented in San Antonio that to have the patient sent back to the OR because only 3 nodes were found positive. And for instance, in the Monarchy study, you had to have like 4 nodes. Whereas in the Natalie study, it was very nicely that they stayed away from the node positivity so much. They presented in San Antonio, and it's just food for thought, that sending back the patient to the OR to have the number of lymph nodes increased from 3 to 4 means that they did a risk analysis that the numbers needed to harm to induce severe lymphedema is 1 out of 11. The numbers needed to treat or to operate on to prevent 1 recurrence event is 1 out of 105, thereby supporting the fact that there is no need to send the patient back to the OR to increase the numbers of lymph nodes from 3 to 4 positivity. And that's what's so good from the Natalie study, that it stayed away from this lymph nodes.
Correct, yeah. Now there's a consensus. We don't have to send patient back to OR just to prove a point of meeting a criteria or not. Okay, that's that. Thank you very much.
Thank you so much. So we'll skip the coffee break and move on to the next exciting session. We have our moderator, Dr. Dalia Shorbaji. She is a consultant medical oncologist at Sheikh Shakhbout Medical City, my dear colleague and friend, and Dr. Saeed Rafi, who's a consultant medical oncologist at Medi Clinic and board member of the Emirates Oncology Society. Dr. Dalia, you can go.
Okay. Thank you so much, Aida, for the kind introduction, and congratulations for today's meeting. It's my pleasure to open the second session for today's meeting. So the topic of this session will be the new insight in breast cancer. And the first speaker with us, Dr. Ahmad Shash from Cairo. He's the medical director and general manager of Breast Comprehensive Cancer Hospital, NCI, Egypt. And he's going to talk to us about the impact of prior treatment, the ACR1 mutation, landscape, and co-occurring of PEC3 pathway in breast cancer. Dr. Ahmad, thank
you. Thank you, Dr. Dalia, for the kind invitation, for the kind introduction, and I'd like to thank Professor Aida and Professor Humaid for the kind invitation. It's really interesting. And I really like the discussion and the debate that was there by the previous one. However, this is the reality. We are featuring more and more armamentarium, and we need to identify what are the possible strategies, the biomarkers, trying to identify who could benefit more. And I like the comment of Professor Nuhad as well about real-world data. Real-world data is important to complement the phase 3 studies. It's really interesting, and definitely it adds to the understanding of how to move. The biomarker, this is a comment as well, it's a hypothesis generation for future trials. So this is the context that what we do. So this is one of the earlier trials that's for oral SERD, the Emerald trial, the Elestaracent, and the impact of prior treatment, it's ESR1 mutational landscape and the co-occurring PI3K pathway status on real-world Elestaracent outcomes in patients with hormone receptor positive, HER2-negative advanced breast cancer. So this is the real-world data that was presented as a poster spotlight session in San Antonio. And definitely, as we all know, the approval was based on the results from the Emerald trial, and clearly the PFS was of 3.8 months versus 1.9. There's a lot of debate that this is a very short time interval to base an approval. It was a debate between the US and the European institutions whether to approve it or not. However, here the authors tends to large clinical genomic database to assess the real-world use of Elestaracent and examine the impact of prior treatments the type number of ESR1 mutations co-occurring PI3K pathway alterations on the clinical outcomes. So patients with the hormone-positive, HER2-negative ABC were identified via the database. Patients with ESR1 mutation detected on circulating tumor DNA within 6 months prior to the elacestrant started and treated with, and after FDA approval in January 2023, and were included. The real world time to treatment discontinuation, the RWTDD, and the time to next treatment were analyzed as approximate outcomes for the PFS. Overall survival was also estimated. Patients were required to have more than 28 days of follow-up after the first claim to be included in the outcome analysis. So there was the use of the non-adjusted Kaplan-Meier curves were generated, 95% confidence interval, Cox regression hazard ratios adjusted for patient age, gender, year of the circulating DNA result, and the line of therapy were used. Definitely the oncogenic alterations in the AKT1 PTN and PIK3CA with an FDA-approved targeted therapeutic indication were included as the PI3K pathway alteration. So actually you can see it's a huge database. More than 42,000 patients were identified. Going into the funnel, those who were included is 756. And that adds to more patients that were the initial Emerald trial that have the similar part of the 756 patients who have a validated test within 6 months prior to the start of the therapy. And clearly, you can see that here the majority of those patients who were included in the study have a bone, and 73%, brain 9%, 31% had liver, and 15%. So basically, they can have much of bone and liver or something else as well. However, the therapy exposure was more than what we expected from the Emerald. That's the real world data. When drug is approved, that's not the same as the clinical trial. And as well, the type of ESR1 mutations, the most frequent to have is the D50, the D538G, the Y537S. Those are the highest. But actually, more patients not have only one ESR1 mutation, but have multiple ESR1 mutations. And that's you can see from the ESR1 mutations at baseline. Of the 742 patients eligible for outcome analysis, the overall median real-world time to next treatment was 6.43 months, and the median real-world time to this treatment discontinuation was 4.6 months. So patients had a similar TNT, TDD, and the OS was not pictured when receiving elacestrant as a second or a third line, so it didn't differ too much of the type of therapy, whether it is a second line, third line, or a fourth line. And what they show as well, that without prior fulvestrant, have those with previous fulvestrant exposure have a tender to have a better real-world time to next treatment. So that means that if you don't use a third prior, that it will have a higher exposure, that it will have a higher response to the oral third. Patients with more than or equal to 4 ESR1 mutations or 3 had a significantly worse. So that means multiple ESR1 mutations at baseline could not be the ideal part for the treatment to go on. Similarly, that no difference was in the real-world time to next treatment and the real-world time to treatment discontinuation when you have the baseline ESR1 mutation by the specific ESR1 mutation that is being said. So patients with the oncogenic PI3K pathway, and that's very important as well, had worse if there is an activation. If there is a PI3K alteration, they have a worse to respond to the elacestrant. So the authors concluded that the clinical genomic data sets demonstrate real-world outcomes in more than 700 patients with ESR1 mutation, advanced breast cancer patients treated with elacestrant, A majority of patients in this cohort received more prior therapy in comparison to the Emerald study population. Despite this, clinical outcomes in this cohort measured via the real-world time to treatment discontinuation and real-world time to next treatment exceeded the PFS reported in the Emerald trial, and they being due to multiple factors impacting patient selections and restaging protocols, which can differ in trials versus routine practice. So the outcomes did not significantly differ by the specific ESR1 mutation allele, prior fulvestrant exposure or elastricant, but however, patients with more than or equal to 4 ESR1 mutation had significantly worse outcomes compared to patients with 1 ESR1 mutation, suggesting a possible relationship between the complex ESR1 mutation and polyclonality and the response to endocrine therapy. Definitely, the oncogenic PI3K pathway co-mutation were associated with a negative prognostic impact on elastricant treatment duration and survival. Most alterations were PI3K mutation, while a minority were AKT1 or PTEN alteration. And the multiple targeted therapies are available, definitely, including 4 drugs targeting the PI3K pathway, and we will be hearing as well for the other SERDs in the upcoming by Professor Nuhad and Professor Hekmat in this discussion. And the armamentarium is increasing, but I guess the real-world data biomarker can help in identifying subgroup of patients and how to sequence treatment. Thank you so much for your time and listening.
I'll start with my question. Actually, it's more like a comment than a question. I think having a biomarker, a definitive biomarker, although we don't have it most of the time, for such an expensive medication is very important, so we can at least know which patient is going to benefit or have a prolonged benefit out of it. And personally, I think this resembles our what we see in our clinical practice. And I think the best people who would benefit from elacestrant, those who had a prolonged exposure to CDK4/6 inhibitor in the second-line setting with no prior fulvestrant exposure and no PI3K mutation. That's personally how I tease all the data together and from my personal experience.
Yeah, I echo completely, Dr. Aida, what you are mentioning, and that actually was also a subgroup analysis that was published from the Emerald trial, that patients on CD4/6 inhibitors more than or equal to 12 months are the higher to respond to the elastricant. And that's actually one of the debates that have based, yes, to go for EMA approval of the drug or not based on these subgroup analysis, and that's a debate that comes. And secondly, I guess that also with the introduction of the ADCs into the HER2-low category, would you tend to exhaust the many endocrinal therapeutics, or you will see that really these patients are not responding well to the CD4/6 inhibitors, then you will probably shift to the ADC, so that's another way. So I completely echo with your comment.
The other point I think to mention is we have currently elacestrant as single agent approval, but all the newer trials are going to be talking about combination.
Yeah.
This may be a moot point because we have seen the AMBER trial. We have seen other trials combining, oral SERDs with something else. I think that's going to be the future, where probably this will be a moot point.
So I completely agree as well, and that's why Professor Nuhad and Professor Hekmat also will discuss about the combination of the third with the CD4/6 inhibitor, the ABEMA. That's what we have seen from the data that was presented in the San Antonio and in previous meetings. But again, this is now, it's our job and our reality to better select the molecules for better patient outcomes. Thank you. Thank you.
Thank you, Dr. Ahmed. Thank you so much. So now it is the time to introduce Dr. Nuhad Ibrahim. I think he doesn't require any introduction. Dr. Nuhad, he's a professor of the Department of Breast Medical Oncology Division of Cancer Medicine, University of Texas, MD Anderson. Dr. Nuhad is going to talk about the elacestrant plus abemaciclib in combination in patients with hormone receptor positive, HER2 negative metastatic breast cancer. Dr. Nuhad, the floor is yours.
Thank you for this nice introduction, and I want to start by agreeing with Hassan's comment. A long believer that the time of hormonal therapy as single agent are gone. And I'm not going to use my time reading the title. This is, again, I think it's a early data, although not mentioned as a co-author, but I am the one of the collaborators on these trials. How to move on? Okay, thank you. So following the endocrine therapy with CDK4/6 inhibitors, by the way, this is the easiest presentations I can make because I don't have to defend anything. In patients with ER positive HER2 negative, tumors eventually develop resistance, either because of intrinsic alterations in the sense cycle, the down pathway of PI3K, AKT, mTOR pathways, or acquired ESR1 mutations, which can be up to 50%, also dependent upon how many prior hormonal therapy the patient might be exposed to. In phase 3 Emerald trial, single agent elacestrant significantly prolonged median progression-free survival with a manageable safety versus standard of care therapy, leading to the first oral SERD approval in ER positive HER2 in ER mutated patients. And patients with ER mutation tumors had 45% reduction in risk of progression or death. And just to make Dr. Hikmat's job more difficult, and also 30% in non-mutated tumors as well. In patients with more than 12 months of prior ET, CDK4/6 inhibitor, and ESR mutations, with elacestrant was 8.6 months versus 1.9 months with standard of care therapy. So the rationale here was a combination of elacestrant and abemaciclib was to overcome different resistance mechanisms and enable an all-oral regimen. In elacestrant phase 1B, the recommended phase 2 dose was elacestrant 345 milligram and abemaciclib 150, overall response rate 25%, and clinical benefit at 16 weeks 75. Actually, I am the PI on this part of the study. So the PK analysis showed no significant drug-drug interaction with a manageable safety. Going back to the elacestrant data, actually it was planned to treat patients with brain metastasis, and this was phase 1B of that study. Now we are in phase 2 trying to see its efficacy on brain metastasis actually. However, this data is a pooled analysis data, updated safety and preliminary efficacy with elacestrant and abemaciclib combination in patients with prior ET CDK4/6 inhibitors for the ongoing ELECTRA phase 1B portion and ELEVATE phase 2 part of the study. So these are the designs of the studies, ELECTRA phase 1 and ELEVATE arm C, which looks at elacestrant and abemaciclib based on the data that we found out in the ELECTRA phase 1, which basically 345 milligrams and 150 milligrams BID. And the inclusion criteria comes very much of overlap between the two, because in the ELECTRA 1, Now we are looking at its effect on brain metastasis, because elacestrant crossed the blood-brain barrier, and there is also data about abemaciclib, in addition to other CDK4/6 inhibitors, efficacy in brain metastasis. Elacestrant and abemaciclib in the ELEVATE arm do not look at the brain metastasis, but just to confirm the efficacy in these patients who were not exposed to prior abemaciclib. So the baseline characteristics of the patients is illustrated here in a very busy slide, only to show that the patient's characteristics in all three arms evaluated in this database are pretty much similar to each other when it comes to performance status, metastatic sites, number of mutations, prior endocrine therapies and resistance to it, including palbociclib, ribociclib, or the combination, because some patients may have received palbociclib and ribociclib as well, and the hormonal therapy exposures that include fulvestrant, AI, tamoxifen, or both, and the prior lines of chemotherapy. About 2/3 of them were chemotherapy naive in this database. The adverse events on these two trials showed that the combination is reasonably very well tolerated. Of course, when you give abemaciclib, you always have to give room in the restroom because there is a lot of diarrhea there, but it is manageable in many ways with pre-medications that can need to be a very extensive pre-medication, but it is generally speaking end up with a grade 3 of not more than 3 to 5%. Nausea is quite common, but mild. Vomiting also very rare, as well as fatigue. So basically, generally speaking, the regimen of elacestrant as abemaciclib in our experience and in my colleagues' experience also, it has been pretty much well tolerated. When you look at the effect of this combination, again, it shows clinical benefits. We only had a couple of CRs, but this is a very high indicator of efficacy. But in the PR rate and SD, stable disease rate, it has been very significant, and this came up to about over 80% of the patients. And at the 24-week clinical benefits, again, it was very significant, at least in the ELECTRA group of patients, because the observation period on this data was 7.5 months. However, on the ELEVATE, it was very short, about 4.5 months, and therefore it was not included in the analysis here. Patients show that median progression-free survival pretty decent, about 7 to 8 months, and patients, however, as mentioned earlier, who was put on the trial for 12 months from the prior CDK4/6 inhibitor shows much significantly better progression-free survival over 16 months, which was very well welcomed data. Of course, it's all subject to further observation in the future, allowing time for maturation of the data. And the dose levels on the ELECTRA trial showing that different dose levels continues to show a different progression-free survivals, which was really pretty amazing, and that's why we went on going with the approval for the phase 2 and on the steering committee to the lower dose levels, because we find that the efficacy is about the same. So we in an attempt to minimize the cumulative toxicity of these drugs. When you look at it in a graphic form, and here the authors of this poster put the different categories and also listed as a reminder of the different patient characteristics of each subset analysis. of all the patients versus those who have prior CDK4/6 inhibitor. And it shows for all patients it is 8.7 months. And for those who have a prior CDK4/6 inhibitor greater than 12 months, it was 16 months. And when you look at the ASR mutated versus ER non-detected, I think that was the trigger to put this poster together, is to show that, again, the clinical benefits is about very much comparable, 8.7 months versus 7.2 months. And this is exactly, they repeated the curve here. I don't know if they wanted to emphasize this data so that you can remember the numbers, but they are pretty much significant. On the ELEVATE arm, which it was designed not to treat the brain metastasis, but to treat or to as a clinical continuation of our phase 1B, just to confirm it in a phase 2 trial. It shows that there was some complete responses, but definitely the median progression-free survival was too early to report because the observation period was only 4.5 months. The conclusion of this poster is that in patients with prior endocrine therapy and CDK4/6 inhibitor, the safety of elacestrant and abemaciclib was consistent with the known profile of abemaciclib, and standard endocrine therapy and no new signals were observed. They really say known profile. Actually, it was only reported by us only in posters in different meetings. It's not published or peer review in a peer-reviewed journal yet, but I believe that it is real. No grade 4 adverse events, and I agree with this as well. Elacestrant and abemaciclib showed clinically important efficacy regardless of ESR mutation status, and I think it's a rebuttal by Stemline against FDA, who refused to approve the drug in non-ESR mutation. They made their point here, but again need to be confirmed in larger numbers. I think there is value there, and I hope further follow up on this prospective database, that this is an early reporting of it will confirm this issue. And a median progression-free survival of 16 months in patients who have received CDK4/6 inhibitor more than 12 months earlier is, again, a very impressive result as well. The phase 2 portion of the combination of elacestrant, 345 milligrams, and abemaciclib 150 milligrams per ID is currently ongoing. And as I said, these two trials address two issues: one, brain metastasis, and the other one, confirmation of a systemic disease, not necessarily including brain metastasis. Elacestrant could become an ET backbone in combination with abemaciclib in patients with ER-positive HER2 metastatic breast cancer due to its potential to extend progression-free survival, enable an oral treatment option, and delay chemotherapy or ADC-based regimen. These are all speculative points, but definitely it's an objective to any clinical investigator to achieve these objectives as well. Thank you.
Thank you so much, Dr. Nuhad. I think we have time for one question. Again, Dr. Hassan.
No.
We can't resist. So I think the...
Hassan becoming Vogel of ASCO.
The elephant in the room, obviously we don't want to be sort of brainwashed by a drug company too much, you know, when we combine stuff and say, okay, it works for all groups. Don't you think we need a really randomized trial in those non-ESR1? Because we have excellent data with abema plus fulvestrant in that situation. If you haven't used fulvestrant, and it's now much cheaper than elacestrant. So before saying, well, it works in both, although that 7 months looked generous, but don't you think we need to really study that group versus fulvestrant abemaciclib?
Well, always randomized trials is the ideal answer to any question. I agree with you, but how quickly the field is developing and evolving with newer agents showing up, I think it may become very difficult to do a study like this. Yes, Sana. There's one here.
Thank you. You know, I echo Hassan. I was just waiting until Hikmat is done with his talk to raise this discussion. Just curious, when we say the time is over for single-agent hormonal therapy, and I'm very simple-minded, I have to understand to be able to practice. Yesterday, I was discussing at, you know, Naj's conference, the AUB breast cancer meeting, I was discussing neoadjuvant endocrine therapy. And to me, neoadjuvant translates into all data in adjuvant or even in metastatic. You have to look at molecular. We know single agent works. And to be generalizing with all these new data and new drugs in the field and say give it to all patients, every one of us here in the room have treated patients with single agent hormonal therapy and they stayed on it for like 10 years, doing very well. And there are subsets that really progress within no time. So we know we have primary and secondary endocrine resistance. We need actually take this data with a grain of salt. This data is expected. It's not a surprise. You said that yourself. You were the PI on a phase 1B study. You know it works. And, you know, I would definitely bet my money, it will work. However, it doesn't make any sense with all these drugs, and they have side effects. They're not like single agent, to accept it for all patients. It's time to look at subtyping of patients, identify clinical markers, doesn't have to be, you know, very difficult biomarkers, and identify subsets of patients who could benefit from this financially toxic regimen. Elacestrant is a great drug because it's oral, but fulvestrant is a great drug. The problem is it's intramuscular. And we both come from the time when fulvestrant didn't work because it was badly dosed. So do we know if we continue with fulvestrant every 2 weeks, it doesn't work? Probably nobody has done it. Probably it works. It's better inhibitor or oral downregulator. So we need, I believe, this is excellent data. For us as clinicians, especially in this part of the world, we need to identify those patients who really need it, not generalize. At least this is my perspective on this data. What do you think? Doesn't make any sense to all patients.
You know, I agree with a concern about your comments. First of all, we are in the arena of genomic medicine, and it is evolving. And you remind me when I was very young, early in oncology, and I used to say back then, I'm talking about 35 years ago, why we have 7 types of leukemia and only 1 type of breast cancer.
Absolutely.
And now I'm very pleased to see that it's breaking down based on the genomics. I used to say why patients who have squamous cell carcinoma of different organs are treated the same. And at that time, we did not understand why only genomics tells us. And now what we are trying to do. Why this data was put together, really, I do not know. They did not tell me. I had a little bit concern about it. Maybe to answer what Dr. Abdelrazak is going to say a little bit later. Is it seeking another indication or not? I do not know. But I still believe that the patients who do not have ASR mutation did benefit from elacestrant as a single agent. The FDA did not like the data for different logistical reasons, more than data reasons. They evaluate their data on their own without consulting the other experts on that, and they decided it is safe to give it only to ASR mutations because now everybody is focused on targeted therapy. But you know, in some ways I agree with you, but I should not stop us from generating data like this. And when necessary, probably we may end up doing randomized trials. But again, many times randomized trials is very difficult to do because the horse is outside the barn.
Thank you, Dr. Mahad. Thank you so much. It's my pleasure to introduce Dr. Hikmat Abdul Razak, the Deputy Director of General or Chief Medical Officer, Professor of Chairman of Department of Internal Medicine, King Hussein Cancer Center, Jordan. Dr. Hikmat will talk to us about the EMBER-3 trial, oral SERD plus CDK4 abemaciclib in patient with hormone receptor positive HER2 negative. Dr. Hikmat, the floor is yours.
Thank you. Assalamu alaikum. It's just a follow-up what Dr. Ahmad and Dr. Nihad just mentioned. My job is going to be a bit easier to talk to you about another SERD, in this case, imlunestrant, another just SERD with the new things. I think this. Can somebody help me with this? Okay, so to make it easier, the title is really too big. This is what the EMBER-3 trial is all about. So the setup is really about advanced breast cancer, patient with ER-positive, HER2 negative, who were pre-treated with endocrine treatment, and those patients were randomized to receive one of the three arms: the imlunestrant alone, imlunestrant plus abema, or standard of care endocrine treatment. In this case, exemestane or fulvestrant. And this study was published in New England the same day was presented in San Antonio. So that's if you need more details, it's already in print in New England. And this is the disclosure of the author. And just to take you into the context of this, as Nihad and Ahmad mentioned, that ET plus CDK4/6 inhibitor are becoming the standard of care, despite all the comment that we heard. I mean, combination therapy is the standard of care nowadays for ER-positive, HER2 negative, advanced breast cancer. And just also illustrated that the continuation of the CDK4/6 inhibitor beyond the progression with endocrine treatment, at least with abemaciclib, at least in a subgroup of the patient with ESR mutation, is the standard of care, as Dr. Nihad tried to push for this. Abemaciclib has shown benefit in this subgroup of patients. Fulvestrant, that's what the author mentioned, is a good drug. However, there is issues about the efficacy, specifically in patients with ESR mutated, and there was a mention of the tolerability and the side effects, though we do not see it in a daily practice about it being an IM injection and not an oral drug. Elacestrant is a good drug, illustrated in the previous two studies. However, there was a mention that this drug is both the agonist and antagonist, while the drug under discussion today, imlunestrant, is a next generation. Two things. A, it's a brain penetrant, and this is will illustrate in the last slide of this presentation about the value of this drug in a patient with preventing brain progression. And it's an oral, and it's a pure ER antagonist and not agonist as the elacestrant. So this is the in vivo efficacy. The curve in red, the lowest one, illustrated when you combine imlunestrant with abemaciclib, you get much of inhibition, a lot more than if you give it with the fulvestrant or you give abema or fulvestrant alone. And this is the amount also of the suppression when it comes to partial response or stable disease. Very few patients who had progressed in the disease in the blue bars here. So the EMBAR-3 study is really about ER-positive, HER2-negative, the males and females, the pre- and post-menopausal, who had the adjuvant, the endocrine treatment, but had a recurrence on or within 12 months of the completion, i.e. resistant to ET, or advanced breast cancer who had progressed and again, aromatase inhibitor plus minus CDK4/6 inhibitors, and no prior therapy were allowed for advanced breast cancer. And those patients were stratified according to whether they had previously been treated with the CDK4/6 inhibitor, also stratified about the absence or presence of visceral metastasis. So the 3 arms, the imlunestrant at 400 milligrams once daily, or standard of care, in this case, the fulvestrant or exemestane, or arm C, which is a combination of both imlunestrant and abemaciclib. And the primary endpoint about the investigator-assessed BFS for A versus B, A versus B. When it comes to all patients, the first endpoint was with ESR mutated patient, or C, the combination arm versus the imlunestrant alone. And there's also a couple of the secondary endpoint, including the overall survival and safety profile for those drugs. As you see here, close to 350 patients in the first 2 arms and 213 in the third arm. And I need to illustrate here that in the imlunestrant arm, there was 72% of the patient who had a progressive disease on the drug, versus the 78% in fulvestrant or exemestane. However, the combination of imlunestrant plus abemaciclib, only 53% of the patient had a progressive disease on the drug. And this is the key characteristic differences between the 3 arms. All patients were a bit on the older age group with a median age of 61 years. As you see here also, if the Americans don't really care about diversity anymore, but they did, at least in this case, lots of patients are from outside the Americans. We have Asians, and close to 25% of the patients, and others almost 1/3. Also, 40% are mutated, and also another 40% or so have the PI3K mutated too, which really goes with the standard what we see. Again, when it comes to visceral metastasis, the 30% or so did have liver metastasis. Bone-only disease represents less than 25% of the patient. Also, as you see here, the patient, the 2/3 of the patient, they had advanced breast cancer who progressed on endocrine treatment with advanced breast cancer. Definitely, as you see here, lots of those patients were treated in the advanced stage, not in the adjuvant setting. And as you see here, all 3 CDK4/6 inhibitors were utilized, but mostly Balbo in 60% or so, Ribo in 1/3, and minority with the abemaciclib. This is the result when it comes to the subgroup with ESR mutated patient. As you see here, at 6 months, there is a difference in BFS, 44% versus 32%, and that also at 12 months, 25% versus 37%. When it comes to absolute number, and here we have in the discussion whether does it worth that much money for this 5.5 to 3.8 months, less than 2 months difference. However, when it comes to statistics, it made it to statistics. This is close to 40% reduction in the risk of progression by utilizing this drug. But I want you to remember this slide. If you use it in ESR mutated patient, the difference is less than 2 months, though when it comes to significant, it is really significant. And now this is a subgroup analysis just to demonstrate that it did work in both patients with bone-only and patients with visceral metastasis. It works also with a patient that had previously been treated with CDK4/6 inhibitor or not, and also whether the PI3K mutated or not. So all subgroup benefited from the drug. That was in the ESR mutated patient. Now, when it comes to all patients, without really looking into ESR mutated, I put it in one slide without really trying to define it. there was no difference. I mean, when it comes to progression-free survival, 5.6 months versus 5.5 months, and the hazard ratio is not really significant either. Now, when it comes to the combination of imlunestrant plus abemaciclib versus imlunestrant alone in all patients, regardless with the ESR mutated, and here is the value actually. At 6 months, 66% versus 40, and at 12 months, 42 versus 27. And when it comes to the difference here, the absolute difference, it makes any more of a sense. 9.4 months versus 5.5, and this reflects close to 45% or so decrease in the chances of progression and the combination of imlunestrant plus abemaciclib. And this is again to demonstrate the same thing as before. The drug did work with the liver metastasis, bone-only metastasis, with the patient being exposed to CDK4/6 inhibitor or not, and whether they are ESR mutated or PI3K mutated or not. And this is the real value about this combination. And this is again about the progression-free survival in the left arm curve. This is ESR mutated, and the other one without ESR mutated, which means that if you want to use the combination imlunestrant plus abema, you don't care about being mutated ESR1 or not, which make it a bit easier to manage in a daily clinic without having an access to do ESR mutation or not. So this is the consistent benefit of the combination regardless of the ESR mutated. And now also, whether or not patient been previously exposed to the CDK4/6 inhibitor, you see curves on the left. This is a significant difference. And also patient with PI3K mutated, which is 40% of the patient, regardless of the status of PI3, there was also a difference in favor of the combination. And this is again, when it comes to subgroup analysis, patient with prior, this is about overall response rate. This is one of the secondary endpoint. In here, imlunestrant versus standard of care, there is no difference. But when you add the imlunestrant to abemaciclib, you see the bars in red with overall response rate much, much better than either imlunestrant alone or the standard of care fulvestrant or exemestane alone, illustrating the value of this combination in all patients regardless of their ESR status or not. And this is the slide I promised initially. I will show you that just because this drug might penetrate the CNS, and this is the difference when it comes to a brain metastasis. This is the upper curve represent chances of progression into the brain without the drug versus the one with the blue one. This is ESR mutated versus all patient. Again, it's better for ESR mutated ones. So there's a trend toward lower rate of CNS progression with imlunestrant, and the hazard ratio is probably significant in both the arms. This is overall survival data is immature yet to claim an overall survival, but you see there is a trend in favor of the combination. And here the important thing is regardless of the ESR being mutated or not, which means that in a regular clinical setup, you can use the combination if you even don't have an access to do or not to do ESR mutation. And this is the safety, tolerability, and as you see here in the summary, there's no much of a difference. A grade 3 toxicity is kind of predicted from the previous studies with the abemaciclib. Little diarrhea here and there, but this is manageable. Grade 3 diarrhea, 80% or so, and only 4% had to discontinue treatment. To conclude, there is a significant advantage of using imlunestrant and in patients with ESR mutated only. However, if you add it to abemaciclib, the significant improvement in BFS is a lot better with the combination regardless of the ESR mutation or not, and the safety is predictable, which the last word and the last conclusion that imlunestrant as a monotherapy and for a patient again and again, regardless of their ESR mutation or not, make a difference. Last thing, this is again, if you need more detail, the study is up in New England. However, I must say that the drug is not approved yet for what we just mentioned. With this, I stop and thank you.
Just one follow-up question.
I thought, Hassan, we agreed on the table, not...
So again, I think, as you mentioned, maybe sometimes when drug company want to expand the indication, we have to read between the lines. You presented the data with single agent. Clearly, the benefit was mainly in the ESR1 mutation over standard of care endocrine therapy.
Absolutely.
So adding abemaciclib, yes, it's showing benefit in all comers. But again, just I commented with Dr. Nuhad's presentation, we don't know in that case if abemaciclib fulvestrant is going to do the same. Probably it will, if I have to predict. What do you think of that kind of strategy to try to tell us use it in all comers?
I agree with you. To add to your comment, I'm not sure that this is a class effect, whether this is not only abemaciclib, does it go with the balbo or ribo? And whether if you use it, faslo or even elastorin, these kind of things. We don't know. Those are unanswered questions. But we go with what we have. What we have a drug, if you combine it with abema, which is available, and you didn't have to have a sophisticated kind of molecular testing, and this is probably an option for a patient who progressed on previous CDK4/6 inhibitor. That's the positive part about it. I believe the drug will be soon approved, and I think this is really feasible with some limitation about the cost effectiveness and what to do in the next morning for those patients.
I have a question here. Okay.
Just quickly to follow on Hassan's comment, I was actually impressed. The hazard ratio for abema with immunoresistant and the progression-free survival is a mirror image of the hazard ratio for fulvestrant with abema, and the progression-free survival 11 months is literally the same. So really, we are not comparing apples and oranges, but the benefit is literally similar to what we have seen when abema was added to fulvestrant. And the only advantage I see it as a clinician, it's oral. And probably the blood-brain barrier thing, we have to look at it. So looking at the data again, it is not that impressive for me as a clinician, except for the oral part.
I think I'm kind of, because of my position at the center, I'm a kind of a strategist more than a clinician. I actually love the study, and I think there is clinical implications for two things. A, it's the oral medication. B, in a daily practice where you don't care about having ESR mutation or not, PIK3CA mutation or not. So I think it's practical. It's available, so it makes some sense because you don't have to bring the patient back and forth for injections, even if fulvestrant is work. The only thing would be if the cost is much higher, then we'll start weighing things. But the setup of the two clinical trials is different, so it's difficult to compare the two setups.
No, I agree. That's what I said. The only advantage I see is the oral part, not the clinical.
I completely echo this, but I also want to add something else as well. For you to be able to say that there is a new standard of care or whatever, is that you have to at least show the single agent activity. This drug doesn't seem to have any single agent activity over and above fulvestrant, so I'm not really sure.
No, it does. I showed you on a subset of patients who are ESR mutated. The drug did work in a subgroup which is ESR mutation. Now, that's a subgroup. So if you have your access to molecular testing, this drug as a single agent, it does work. However, in a daily clinical setup where you don't have access to a fully accredited molecular lab, then you can use it with combination of abemaciclib. But it did really work as a single agent.
Thank you, Dr. Hikmet, and thank you for the question and discussion. Dr. Atlar Abu Sanad, the consultant and associate professor of internal medicine and medical oncology, Department of Medicine, King Abdulaziz University, Saudi Arabia, is going to talk to us about the FILA trial. Dr. Tlal, the floor is yours.
Is it? Okay, it's still good morning. So how you're doing? We're good? Okay. So basically, this abstract is very important if you are going to relocate to China and practice over there. I think Dr. Nohad is willing to leave Texas and go all the way to China, right? Especially with Trump, right? Okay. All right. So let's start. Actually, this one is discussing pyrotinab or placebo in combination with trastuzumab and docetaxel for untreated HER2-positive metastatic breast cancer. This is the pre-specified final analysis of progression-free survival of the phase 3 FILA trial. It's the green or the red? Okay, the green. This is the disclosure of the author. Basically, HER2-positive breast cancer accounts for around 20% of breast cancer cases, and we already have multiple agents to treat this subtype of breast cancer. The clinical evidence indicate that inhibiting more than one part of the HER2 will result in better outcomes. So in the first-line setting, the Cleopatra trial proved that the dual monoclonal antibody trastuzumab and pertuzumab plus chemotherapy will give us very good progression-free survival with median of 18.7 versus 12.4 months and a significant hazard ratio of 0.6. Pyrotinab is a small molecule. It is irreversible and inhibits all HER2, or actually the HER family, receptors. It's been presented previously in the FILA trial showing an improvement in progression-free survival with median of 24.3 months versus 10.4 with very significant hazard ratio. As you see here, it's 0.4. Well, they say that the toxicities are manageable, but I will let you decide on this part. So this abstract is presenting the updated pre-specified final analysis. As you see here, patients were randomized to receive either pyrotinab 400 milligram once daily combined with trastuzumab and docetaxel versus trastuzumab and docetaxel, which is not anymore the standard of care. Primary endpoint was progression-free survival, and overall survival was secondary endpoint, among others. The details here, the final the sample size calculation, which is basically requiring around 410 events of progression or death, so they can get into the pre-specified final analysis. Here we have the patient's characteristic, and I would like you to have a look at the bottom two rows. You see that at least 40% of patients on this trial received prior adjuvant treatment. 1/3 of them during 12 to 24 months, and the rest is more than 24 months. The follow-up median period was around 35.7 months for the pyrotinab group, and for the Herceptin plus chemotherapy was 34.3. As you see here, the progression-free survival curve is very impressive, and we see a significant improvement in the PFS with pyrotinab plus trastuzumab and docetaxel. Hazard ratio is 0.44 with significant B. Subgroup analysis showed that all patients benefited equally from this combination. Also, they stratified the patient according to having a previous adjuvant or neoadjuvant trastuzumab. As you see here, the benefit was consistent across those patients. Not only that, but also treatment-free interval, regardless of the duration, whether above 12 months or Actually, 24 months or below 24 months was also significant. Overall survival analysis, though it is showing a trend toward improved survival with the combination, it did not reach statistical significance. What they're trying to tell us from displaying this slide is basically the post-continuation therapy, because, you know, the post-continuation therapy usually impact the overall survival. So looking at this table, basically the post-discontinuation therapy was similar in both groups. Objective response rate and clinical benefit rate as well, and duration to response, all were better in the pyrotinib group. Not only that, but also the depth of response. As you see here, more complete responses and more partial responses as well in comparison to the other arm, and fewer stable diseases. Okay, comes to safety, because as I promised you initially, I'll let you decide if this is something you can manage or manageable toxicity profile. Basically, everyone almost got diarrhea. Around 50% got grade 3 diarrhea. No grade 4 or 5 diarrhea. But as you see here, also the discontinuation rate was around 15%. Drug interruption or treatment interruption occurred in 60%, and dose reduction occurred in around 30%. Most common side effect, again, it's a small molecule TKI, so as you expect, it's going to be diarrhea, some neutropenia, as well as skin toxicity. So after an extended follow-up period, the updated analysis showed that there is definitely an impressive improvement in the median progression-free survival, and there is a trend toward improved overall survival, but not statistical significant. The author says the side effect remained manageable, and as I told you, you decide on this one. And I don't know how we can put this in our right now standard of care and the expanding landscape of HER2-positive breast cancer therapies. Thank you very much for your attention.
I have a quick question. Maybe I did not catch up that clearly from the slide. Was there any benefit in terms of CNS disease?
It was not reported here.
Okay.
But if you look at like previous trials or basically phase 1 or phase 2 trials, early phase trial on pyrotinib, there is a benefit from pyrotinib in patients with brain metastasis. Yes.
So this combination, I mean, is not new, by the way. So when we had lapatinib in the past, there was a lot of trastuzumab lapatinib, but the reason they didn't flourish was just what you mentioned at the end, that the side effect is too toxic compared to adding another, you know, like when pertuzumab came.
Absolutely.
And same in second line when we had TDM1 versus lapatinib. So I think,
as I told you, unless you're going to practice in China, I don't think it's going to be changing anything.
Absolutely.
Right?
Well, it's a good drug, but maybe for later lines, I think it has a potential.
Thank you, Dr. Atlal. Thank you so much for the presentation. So it's my pleasure to introduce Dr. Sana El Sokhn. She's well known for all of us, our colleagues, and she's a known consultant medical oncology from Jordan, oncology hematology, co-chair of the RGSG committee of ASCO, past chair of the International Affairs of ASCO, past president, Jordanian Oncology Society Association. Dr. Sana will talk to us about the association between the risk reduction surgery in patients with BRCA-positive disease from an international cohort study group. Dr. Sana.
Thank you. Assalamu alaikum. Sabah al-khair. You know, I've been tasked with this. First, thank you, Emirates Oncology Society, for the kind invitation. Always pleasure to join here. Thank you, Dr. Aida and Dr. Hamed. Great effort, always excellent organization. You tasked me with a sort of surgical abstract, so I was thinking about it from a medical oncologist perspective, trying to digest and understand what did we learn from this abstract. So, you know, interestingly, I was sitting next to you, remember, at San Antonio when we listened to this abstract, and I was like, yeah, I was in my fellowship when we learned that risk-reducing surgery improves survival, and that it is to be recommended for patients with BRCA carriers. This is like 2 decades. We have known this data. And at the same time, I remember in 2008 giving a talk about the same topic. And when we were in a panelist asking what would you offer your patient with BRCA mutation, I was the only one to say I would offer risk-reducing surgery, but if the patient refuses, surveillance is okay. And I remember I was attacked then. So we as a community take recommendations like with a blind acceptance, some sort of, just similar to what we have seen when the data was impressive a bit ago with the new drugs. So you cannot challenge risk-reducing surgery for patients with BRCA carriers. To the contrary, actually, you can and you may, because we really take that it does improve overall survival or it's beneficial, but we really don't look at the details. This benefit and this abstract is similar to the impact of tamoxifen reducing the risk of recurrence of breast cancer in patients at high risk without impact on overall survival. If you remember, they have already recommended that, but there was no single study to demonstrate impact on overall survival. So let's see, what did they try to do? So the abstract is focusing on the impact of risk-reducing surgery in a young cohort, younger than age 40. They to be commended, they are focusing on this, and we'll see in a minute. And this cohort has breast cancer, so they are not patients diagnosed with BRCA mutation. They already have cancer. And you know, the background, as you know, as I just mentioned, BRCA healthy carriers are recommended to have prophylactic surgery, and it's taken without even hesitation. However, I will show you data to make you think about your recommendation in a minute. We know that patients with BRCA mutation and cancer are also recommended to have prophylactic surgery. However, when it comes to young patients, how beneficial is this prophylactic surgery considering they have competing risk factors? BRCA mutation, they are at risk of pancreatic cancer. Another very interesting topic, by the way. I'm very much interested in pancreatic cancer, and I find it like the cancer of the century to be. They could die of that, so why put them through the hassle of going through surgery when this surgery is indeed traumatic for the woman, not only psychologically, but actually practically when it comes to her reproductive life. And indeed, let me remind you, recommending surgery, prophylactic surgery is a process. We are counselors, we are not judges. So we recommend, we counsel, we need to discuss this data and not give it like it's a life-saving procedure. And before I discuss the abstract, this is a meta-analysis of studies addressing prophylactic surgery for patients with BRCA1 and 2 mutations, not VUS as mutations. And as you can see, prophylactic salpingo-oophorectomy in patients without prior breast cancer does improve outcome. And the hazard ratio is indeed impressive. You're talking about a 50–60% difference. That is also true for patients with prior history of breast cancer. When it comes to mastectomy, which is more appreciable for the patient because she can see, actually, surprisingly, bilateral prophylactic mastectomy for a patient without history of cancer does not really improve overall survival, as mentioned, as detected in all studies so far. There isn't a single study to demonstrate impact on overall survival for prophylactic mastectomy for a patient who has not developed breast cancer. And indeed, it makes sense, because I'm sure most of you have seen patients with BRCA mutations who are in their 80s and still alive without these prior surgeries. And when it comes to patients with breast cancer, the green should have come, actually there is impact on overall survival. So we know that from the retrospective studies. The only thing that I found unique about this study, if you look at this meta-analysis, most of the numbers, does this have a pointer? Yes. Most of the numbers are really small. You're talking about 1,000 patients at most. Look, 500, 200, less than 100. So the numbers included in these studies, most of them are small. The largest was this study with a total of both studies coming to 3,000. So really the numbers you have are very little compared to others. So let's look at the study. The key inclusion criteria is very simple. They're looking at patients with early breast cancer, younger than age 40, with a BRCA mutation, not with VUSs. And they're looking at overall survival and disease-free survival and breast cancer-specific survival with predefined subgroup analysis for tumor, nodal status, subtype of BRCA1, BRCA2, tumor subtype, timing of BRCA mutation. Interestingly enough, I thought I will look at the statistical analysis just to highlight two things. To account for potential lead time bias, they did two sensitivity analyses, including patients with BRCA mutation diagnosed at or before breast cancer, and that can lead to lead time bias because those who are diagnosed with BRCA mutation before could actually have better survival because of lead time bias. And they did a survival model looking at time truncated at time of BRCA mutation. To account for potential guarantee time bias, and I like this one, guarantee time bias refers to patients who are guaranteed to live longer because they have better biology. And those are the subset of patients we know, some BRCA mutations, somehow they don't develop as bad cancers as others, or they don't develop breast cancer or ovarian cancer altogether despite having the mutation. So they had a 3-year landmark analysis where patients included has to have lived at least 3 years. Number of patients included is more than 6,000 registered, but included for the analysis more than 5,000. Those who were excluded, they were excluded for a variety of reasons, different age group, BRCA VUSs, etc. And some of those patients, as you can see, some did have oophorectomy, some didn't. This is the retrospective cohort comparing the impact of surgery versus not. And the median follow-up is actually good, 8 years. So if you look at the criteria, from high-income countries, most of the patients, low-income countries, we are in this part of the world. Yes, UAE is a high-income country, but it's included with the group of countries where we have low and middle income. Unfortunately, the representation is very little. Also, notice the time of BRCA testing, 50% had BRCA testing at or before. So this is a well-selected group of patients where many did know they have BRCA mutation ahead of time. Also, nodal status, 50% of the patients, because they were aware of the BRCA diagnosis, probably they had node-negative disease, which is very good for BRCA mutation, usually discovered later. And BRCA, one cohort is more than 2/3, as expected. So the impact of mastectomy, we know that it was done within a year of diagnosis, median, with a follow-up of 5 years, excellent impact on overall survival. As you can see, 1/3 reduction in the risk of death when you are recommending or hopefully the patient accepting to do mastectomy, contralateral mastectomy at time of diagnosis. And that was true across all different sensitivity analyses. Almost 40 to 50% reduction in the risk of death, and that's what matters. And if you look at the PFO interaction, indeed that was independent of tumor size, nodal status, whether they independent of subtype, BRCA mutation, location, which is very reassuring. So when a patient has breast cancer, there is a definite impact for contralateral mastectomy. Disease-free survival and breast cancer-free survival is more or less similar, with excellent reduction in the risk of death of recurrence of about 40%. Now, when it comes to oophorectomy, as expected, you do see an impact on overall survival 40%, independent of the sensitivity analysis. And if you look at the patients who were diagnosed with BRCA the 50% diagnosed with BRCA at or before breast cancer, the hazard ratio is indeed less, speaking for the fact probably earlier is better. And when you look at the P4 interaction, this is a bit interesting. It is insignificant. It was actually beneficial for all subgroups, but for patients with BRCA mutation, it's a lot more beneficial to have prophylactic oophorectomy at time of diagnosis compared to BRCA2, probably speaking for the fact that BRCA2 mutation carriers tend to develop cancers later in their lifetime. Another interesting, actually, observation, if you notice, HER2-positive patients were the most to benefit. And indeed, this is quite interesting, and the triple-negative breast cancer patients, much less than the luminal-like patients. Probably this is because they are the subset of patients expected to be seen in patients with BRCA2 mutation. So this is like, this goes with the observation that BRCA2 mutation carriers were less likely to benefit as compared. In addition to the fact, numbers could impact this interaction testing, but still it's concordant. HER2 positive, triple negative, and BRCA2 mutations less benefiting from prophylactic oophorectomy at time of diagnosis. Again, prophylactic oophorectomy provided 1/3 reduction in the risk of death if patient undergoes oophorectomy at time of diagnosis. So if the patient undergoes mastectomy, 50%, 40-50% reduction in death. Oophorectomy, 1/3 reduction in death. Are they overlapping? And indeed, when it comes to overall survival, the impact is synergistic, independent. So mastectomy does reduce the risk of death, and oophorectomy does reduce the risk of death. They are not interacting with each other. So it's a synergistic impact. The only thing you would see is that breast cancer-free interval, in terms of relapse, actually there is interaction between both. If you do one, you could help, you probably will have the same benefit as the other. So to conclude, you can see I completely agree that the results does confirm the benefit for patients with breast cancer in terms of reducing the risk of death, risk of recurrence. The favorable impact on overall survival was seen actually irrespective of the BRCA gene. The beneficial effect is more pronounced for oophorectomy in BRCA1 carriers, speaking for the fact more prevalence of hormone receptor positive disease. The effect of both were independent. And finally, yeah, this is excellent data to counsel our young patients who are carriers and having competing morbidities, mortalities from other tumors. That's, I believe, what makes this study unique, that yes, those are young patients at risk for more tumors, still benefiting, unfortunately, from these challenging prophylactic surgeries. This I conclude, and thank you for listening.
Dr. Sana, thank you very much. My question about the recurrences, is it distant or local? Do we have any? No, we don't know.
Unfortunately, we don't have enough data for that. I'm actually looking forward to the published data. Probably it will be more dissected. It's disease-free survival, breast cancer-free survival.
So thank you. At least this is the first, I mean, we always think, or we used to argue, yes, surgery never shown survival advantage. This is a large study showing that. My question to you, did they look at the type of mastectomy? The reason I'm asking, because we are seeing a lot of nipple sparing or skin sparing where the surgeon, it depends from surgeon to surgeon, they may leave a lot of more tissues, and we've seen recurrence in those patients if they didn't get radiation.
Again, I don't have this data. I'm waiting for the published manuscript, but I was thinking about the same question. In the meta-analysis, the studies I have looked at have lumped mastectomy, radical mastectomy with skin-sparing mastectomy. And recently, they are looking into the amount of tissue left by MRI
after doing the prophylactic mastectomy to guide further surveillance. But all studies so far have been looking at mastectomy independent of whether it is radical or skin sparing. Unfortunately, you're right.
Thank you so much, Dr. Sana. Very interesting discussion. Thank you so much. I think this is a time for Lily Symposium. Dr. Hassan Jafar, our colleague and friend, consultant medical oncology at Burjeel Medical City.
Thank you, Dr. Dalia, for this kind introduction. Good afternoon, dear colleagues. So it is a satellite symposium for Lily. And we see how mature the data to shape the management strategies for node-positive, high-risk early breast cancer. And this is a video for the Eli Lilly announcement. So if we can run the video.
Welcome and thank you for dedicating your time to attend this meeting. At Lilly, we are committed to following the letter and the spirit of laws, regulations, policies, and procedures that govern the pharmaceutical industry. We would like to remind you that today's discussion will be dedicated only to information that is consistent with the product label approved in our country. Any questions related to unapproved drugs or indications, dosing regimens, populations, or other information not consistent with the PI will not be answered in this meeting, but forwarded to our medical department. Thank you for your understanding, and we wish you a good meeting.
And by AI. So it's not a human being. So this is a sponsored meeting. So prevention of recurrence and delaying progression is feasible nowadays with CDK4/6 inhibitors. I started with a case presentation. This is a patient with 53 years old woman. She's hypertensive, hypothyroidism, not compliant with the treatment, no family history of breast or ovarian cancer. She's married and she has 6 children. She detected, self-detected lump in her left breast. We did mammogram ultrasound breast that showed it's a BIRAT5. So the lesion was measuring in her breast 1.8 by 1.7 centimeter, and there was a microcalcification as well as suspicious left axillary lymph node. So biopsy was conducted and proven that it is an invasive ductal carcinoma, ER 8 plus out of 8, PR 8 plus, and HER2 was 0, Ki67 50%, and histology grade 3 histology. We did metastatic workup, which did not show any distant metastasis, but as you see that the lesion in the internal quadrant, and we see also left axillary lymph node, there was no internal mammary lymph node uptake or suspicious lesions. So she underwent lumpectomy and left breast axillary lymph node dissection. That showed invasive ductal carcinoma PT1C. It was multifocal, so there was the largest 1.6 centimeter, and there was another lesion 0.7 centimeter, and there was N1A, 2 positive lymph node out of 20 lymph node dissected. The largest was 1.5 without extranodal extension. So this patient also had mammoprint to evaluate because she's most postmenopausal to see if there is a benefit from the chemotherapy, and it was high risk by mammoprint, and we did the BRCA testing, which was the germline wild type. So she underwent adjuvant chemotherapy consistent of 12 weeks of paclitaxel and 4 doses of AC. This patient, by definition, is high-risk patients, and we saw that those patients usually, we know that there is unmet need and there is high risk of recurrence, even with the addition of the chemotherapy. We know that around 30% of those patients who are entitled as a high-risk population, like having positive lymph node, a tumor mass more than 5 centimeters, or they have high-grade tumor, so they have this 30% risk of recurrence at 5 years, and you have 2 out of 3 of these features. And if we look into the data from the SEER data, we see around almost 30% of those patients presented with breast cancer, they have a stage 2 disease, 2A or 2B, with a risk of recurrence ranging between 27 to 37%. Even with the chemotherapy and the hormonal treatment and the ovarian suppression, which we do it. And usually by staging, you see that most of those recurrences happening in the first 2 to 3 years, although they never go to 0, but this continue, but it's much less degree of incidence of recurrence after this year. And we have recurrences up to 10 and more years. And we know that the number of the lymph node also impacted on that risk of recurrence. We see it with no negative lymph node, with 1 to 3, and even 4. We saw that even for more than 4 positive lymph node, the risk of recurrence more than 50%, even with giving all the tools of treatment. And we know that some of those patients are even subclinically metastatic. And in the era before the CDK4/6 inhibitors, we were not able to give them any additional treatment. Also, we know this is not only by stage and the number of the lymph node, also the T, the size of the tumor, and the grade also play a role in categorizing those patients with high-risk features. This is from the SEER data, which is included almost 342,000 with different type of breast cancer, ranging from stage 1 to 3, and they assessed the mortality, which was around 228,000 patients, just trying to stratify the risk category for those patients. And they found that those patients who are having 4 or more positive lymph nodes, or they have histology grade 3 and greater tumor size if they have positive lymph node, those patients form around 12% of hormonal positive disease, and they are among of very high risk category with a chance of recurrence in 5 years around more than 30%. And this is where they stratified the criteria for the monarchy. So those patients, if they have positive lymph node, 1 to 3, they should have either tumor size more than 5 centimeters, or they have to have a grade 3 disease, or if they have 4 or more positive lymph node, regardless to the size of the tumor or the grade of the disease. We also have to know that not hormonal positive disease, not only luminal A, it's heterogeneous within this category, and we see those patients with basal-like and those with HER2-enriched population, although they are ERPR positive and HER2, and those patients usually have more aggressive nature and they have more trend to metastasize as well. So as I mentioned, with all the efforts of extending the treatment of tamoxifen, of switching to aromatase inhibitors, with ovarian suppression, and giving the chemotherapy for those patients, still there was unmet need, and those who are primary resistant to hormonal treatment are still relapsing and having a worse prognosis in this category. And this is just to check the criteria which included in the monarchy. You see it in the purple color, compared with those patients who have outside the clinical the criteria, which is showing in the light blue, which is node negative, or dark blue. So you see there is a big difference between them, and the risk category of those patients almost close to triple negative. So it is an aggressive tumors. And if we look into all the guidelines, whether FDA, ASCO, NCCN, EMEA, or ISMO, they approved the abemaciclib in those population who's having high category population. Also, if we look into the inclusion criteria, because we see that those patients with micrometastasis, they were included in this study, although we don't know what is the subset of patients included, and also the tumor size. Sometimes when we have multifocal, we take the largest one, but here in the clinical trials, they added the size of the tumor. So if you have multifocal, the cumulative size of the tumor, if it is more than 5 centimeters, were included as well in this clinical trials. So this is the design of the trial. We know that 91%
were included the category of approval. Around 500 patients, they enrolled with the Ki-67, which is excluded and it is not in the approval form. So those patients were enrolled either to receive endocrine therapy, standard of care, or in combination aromatase inhibitors plus or tamoxifen, which was stopped later on because of the risk of thrombosis. And those patients, they received it for 2 years. And if you look, those patients is high category, and we know that almost 95% of those patients, they received chemotherapy. And in additional, so those are high risk, in additional of the chemotherapy and the hormonal treatment, those patients received CDK4/6 inhibitors, radiation 95%. The primary endpoint was invasive disease-free survival. So if we look into the primary endpoint, we see that the first 2 years where the patient on treatment, the differences in the invasive disease-free survival were almost 3.2%. But even after stopping the treatment, we see that there was a continuous separation between the two arms, and it's reached 7.9% at 5 years. This is very reassuring that this is a carry-on benefit, because we think that probably after 2 years this will end the effect of the treatment, and probably this line will be converged. So this is a continuous benefit. Even after 5 years, there was a 33% reduction risk of invasive disease-free survival, and the subgroup analysis of all those patients, they benefit from adding CDK4/6 inhibitor, whether they are 1 to 3 or 4 or more, regardless. And then we have distant relapse-free survival, which is another important endpoint where you see that there is a metastasis for those patients. Again, this continues to separate, and it's reaching around 33.5% at 3 years. And if we look here, we see that if you see that the disease, the mortality from any other cause than breast cancer, it's almost equal. So there is no really a toxicity from that treatment that led to higher mortality. And if we look for those who are alive at 5 years, it is numerically much higher in the CDK4/6 inhibitors versus the control arm. But this did not reach a statistical difference. But if you see those patients who have metastasis and they are still alive, it's almost half of those with hormonal therapy. So it is reducing the systemic disease, and probably we know that hormonal positive have longer survival even in the metastatic disease. So longer survival data can be positive if you take it as a surrogate marker for those patients. And if we look into those metastases, type of metastasis, we see around 62%, 62 patients with bone, and 42 in the abema arm, which is much higher in the hormonal arm or the control arm alone. And if we see the separation also for these, it is continued to be separated after stopping the treatment. Now, if we take the safety of the drug, on the other hand, we see that most of these side effects is cytopenia, which is manageable, and we know that this is a continuity of the continuous treatment, so we don't stop that treatment. But the only difference is the diarrhea, and we see that most of these diarrhea are grade 1 and 2. A small percentage is less than 7-8%. They have a grade 2 or more diarrhea. And if we look into the diarrhea, mainly it is within the initial course of the treatment, and those, most of them, they are self-limiting, and they respond to the treatment or the dose reduction. And we see the median time to have it is around 8 days, and we see that the discontinuation number is really very small. It's 5.3% because of diarrhea. If we look into the difference, even if we do the dose reduction, so there was no difference if we reduce the dose in the primary endpoint as well as the secondary endpoint, invasive disease or distant relapse-free survival. So those adjustments for those patients who have side effect can be very useful, and you can retain more patients. So with dose reduction, you retain more than 90% on the treatment. So dose reduction does not impact on the outcome of those patients and also can retain many of those patients. And we know these are high-risk population. And these are just showing the data, whether you do the dose adjustment or the full dose, there is no impact on the primary or secondary endpoint, the invasive disease-free survival or distant-free survival. Again, if you see the quality of life, we see the quality of life. Mainly it is because of the diarrhea that during the treatment it is slightly higher. And this is, it's either light, as you see it, lighter blue, it's a little bit or somewhat deterioration in the quality of life, and mainly because of the diarrhea. And as we mentioned, the dose reduction and supportive measures can help with these. I think the end point or the take-home message that adding CDK4/6 inhibitors, abemaciclib, in this high-risk category where we don't have any other tools to support them, in addition to the chemotherapy and radiotherapy and hormonal therapy and ovarian suppression, those were able to reduce the risk of invasive disease survival by 33% and 33% of distant-free survival. And this is with a long-term follow-up of almost 5 years, which is very reassuring. By this, I finish my presentation. Thank you very much for listening. So if there is any question, Dr. Most welcome.
No, we have to ask the satellites. So obviously great data for high-risk patients. This is, when you look at risk-benefit ratio, of course, it's in favor. My question to you, because most of these patients had chemotherapy, so they are finishing chemotherapy, they are tired, they're exhausted, you come and tell them, we need to give you this now for 2 more years, and you mentioned this potential side effects. So how do you convince patients who, because I'm already seeing that in the clinic, they're already saying, yeah, I don't know if I want more, I thought I was done, etc. So do you prepare your patients ahead of time? And what are ways you may be doing to mitigate those side effects? Like, do you start with lower dose? Do you give preemptive anti-diarrhea medications, etc.?
I mean, this is a great question, and this is a practical question. We know that the data and the inclusion, it is long even after completing all the treatment. So I think it's better to prepare the patient that there is an additional treatment without going with the details of the toxicity. And you have enough period of time. We know that sometimes we give PARP inhibitor for 1 year and then we start the CDK. So there is no rush to start it right away. We start the hormonal therapy. And after completion of radiation, the patient completely recover, then probably we educate those patients about the CDK4/6 inhibitors, and this is the magnitude of benefit. And we know those patients are really high risk, and it is not something gray zone. It is probably the strongest data in this population. What is the cut point for the lower risk? Still, we want to put it, but here we know that some of those patients already they have stage 4 disease. So we are more probably pro to give this treatment. So I think I give full recovery, and probably discussing this like 1 or 2 months after completion of radiation. I tend to go with the full dose, but I have very low threshold to reduce the treatment, but never escalate it again if there is any toxicity.
Any role for ctDNA in this situation? I will be presenting later on ctDNA, but we're seeing more and more data in breast cancer and ctDNA. Are we ready to start applying it in breast cancer?
I mean, these are also great data, but what is the clinical implication of this? I think it's really very difficult. I think with positive circulating DNA, you will be pushed more to give this treatment. But whether they benefit from that treatment or not, this is a big question mark. We know that those have a poor prognosis, but we don't know whether they responded to that treatment or not. But it does make more sense if they have this positive to give it, because you can give it in the metastatic or early. So I prefer to give it in early, at least if I can cure some patient, but we don't have these data to say it for sure.
We have the one abstract presentation that was about the MONARCH trial with the ctDNA. At least we have seen if you clear the ctDNA, then we know your benefit is there, at least.
The problem, that it has to be serial, and this serial, again, we don't have level 1 evidence, and it's costly to implement it in a clinical practice, probably for well-educated patients to do it, to guide you like a tumor marker, but it's by far more sensitive than this. Yes, I totally agree.
Yeah. And some of them become negative.
Yeah.
that you may consider it secure, because it's negative also, it can be again after a while positive. So I think the data is not very well established to say it for good.
Dr. Hassan, you said in the trial they did for multifocal disease, they did the sum
Yes.
of the disease. So the tumor size is like 5 centimeters or higher. So how this data will, how you will apply this practically? So you will consider the same, or you will consider the biggest tumor size? How you will manage that?
I mean, sometimes we know, again, as I mentioned, the cut point where to include this is still gray, but we know those for high risk. In the study, that if you have multifocal and you have like 2.5 centimeter and another like 3 centimeter, they consider it as more than 5. So they accumulate additive rather than what we do it in the staging. So we say T2, it is less than 5 centimeter. But in the study, they included the sum of the size of those tumors.
Does it affect your decision when you have a patient with multifocal? For example, the tumor size is 2 centimeter and the lymph node is 1 lymph node positive.
Yeah.
To affect your decision about it?
Again, if you know that in our tumor board, always we try to make it, to extend the approval of this drug. And when we have ribociclib, which is extending it even beyond, so we have probably more likely to have this inclusion. But this was included in the study, which make you more confident to include it as well. Thank you very much.
Then I think by this we close the Lilly Symposium. And we are waiting for the debate between Dr. Abu Gheda and Dr. Saeed Rafi. They are going to talk to us about if we can skip the adjuvant radiation therapy, post-neoadjuvant chemotherapy in patients with triple-negative breast cancer. So we'll start with Dr. Saeed for you.
So good. I like the energy and the spirit. So if you can scan the QR code to start with the voting, then we'll start the debate. Can we go back to the code? It's over there.
You lose one vote. I'll vote for you.
Where are what they call it? Okay. I need to vote too.
Breast conserving surgery.
No.
By the way, this is not the question we agreed on. This was just changed right now.
No, wait a minute. It's still the same concept.
Yes, breast conserving surgery. That's what I meant. And this is a question that just came up.
Okay, I think we can end the vote. We have impressive 56 voter, and I think, Ibrahim, it's time to prove
So they want to omit. So most of the audience wants to omit radiation after breast conserving surgery. After breast conserving, okay. Let's see, we'll change it.
I know.
Okay. No, really, thank you. Okay, should we start? Okay. Okay. So, good afternoon. It's great to be here. First of all, I really would like to thank Emirates Oncology Society, Aida, Hamid, and for organizing this. It's really a very nice talk and debate that I will start with. Again, I remind everyone what was the actual question that I was asked. So the actual question was, can we skip radiotherapy for patients with triple negative after receiving complete PCR? It wasn't stage 1. It wasn't what was just asked. So my presentation is this, but yet I can still convince you how you cannot skip radiotherapy. Before we do this, how many radiation oncologists or People who do radiation, maybe a clinical oncologist are in the room. Can you please? So we are 1, 2, 3, 4, 5. So we are 5. I don't want to say against because we're with the team. So just to remind everyone, ABCs of breast cancer, systemic therapy, surgery, radiation. We all know that different cancers behave differently, and triple negative definitely has the worst outcome. It's usually associated with younger age, BRCA mutation. It's an aggressive morphological features, and we know from all this data that triple negative actually behaves worse, even for the same clinical stage for ER, PR positive and HER2 positive diseases. There is lack of targetable receptors in triple negative disease, so to keep that in mind. And again, if we look at some data, this is very interesting to see that in triple negative breast cancer, when we compare breast conserving surgery with adjuvant radiation versus mastectomy, there is an average improvement in local control and in survival. This raises a question, does radiation have only a local role, or does it have something to do with changing the microenvironment of the disease and making it more effective? Because for the same stage, if you stratify patients, and this is a very large, nice paper actually, authored by Yusuf Zaidan, you can see that actually no, breast conserving surgery with adjuvant radiotherapy does better than mastectomy with the same patients in triple negative disease. So please keep this in mind when you want to omit radiotherapy. Saifi, Omar Saifi. Another important point we need to consider is the initial lymph node drainage of breast cancer. We always think about breast cancer. We know breast cancer can drain differently. If we're talking about the upper inner or lower inner quadrants, there is a very high chance that these cancers drain to the internal mammary chain lymph nodes, which are not sampled in any surgery that we do. So also keep this in mind, our dear medical oncology colleagues, when you want to omit radiotherapy. Some patients might have internal mammary chain, and we know from all the trials that the value of adding IMC lymph node radiation for breast cancer. Again, we have to admit, we are in an era of new systemic therapy. We have to admit that the immunotherapy has really changed the games. We are seeing much more complete pathological response in breast cancer. It's specifically triple negative. However, is that enough? Again, because the question was not for N1, I have this case for a 35-year-old, negative family history, BRCA negative. She has a huge breast cancer, as you can see, triple negative disease. And you can see the internal mammary chain lymph node, the supraclavicular lymph node. It's an N3C disease with no evidence of metastasis. Of course, now we are in the era of personalized medicine, but interestingly, today I saw a tweet. For all triple negative patients, they all get Keynote 522. This is very personalized. She got neoadjuvant, and as expected, she had an excellent response, both radiological and clinical. She underwent left modified radical mastectomy, and she had a residual in situ disease with node negative disease, 8 out of 12 showing treatment effect. So for this case, just by the show of hands, would anyone omit radiotherapy on this patient? Okay, none. Great. So at least we know that radiation. However, we know that data is emerging based on just one paper, which is an abstract so far, which is the B51. For those of you, I have the full slides of the B51. I put it on purpose so that I'm not hiding anything. So in the B51, this is patients with T1 to T3, N1, patients with biopsy proven received neoadjuvant treatment, and they were stratified. So for those who had lumpectomy, patient had breast radiation. So breast radiation is not omitted in this trial. However, who had mastectomy, there was a question of adding post-mastectomy radiotherapy. But none of those patients who had a lumpectomy omitted their breast radiation. So the question, even to Dr. Saeed's question, which was just added, there is no data to support this. Again, this is the objective, and just for the sake of time, and I'm highlighting N1 because this is only N1 patients, and they received neoadjuvant therapy, as well as, so the primary endpoint was breast cancer recurrence. We all know this data by now. It is a very, very well designed trial, which I had the privilege actually of enrolling in when I was doing my fellowship at MD Anderson. I just want to highlight the age part, right? Because we always talk about young patients as having, more concern. And in this paper, with all fairness, there was a good fairness of patients who are less than 49, but we don't know how much were actually less than 40, which is something that we're seeing more and more common, unfortunately. Again, triple negative, 21%. So it wasn't a trial that was powered to answer this question for triple negative. Of course, the outcome is very encouraging. There is no benefit of regional lymph node radiation. This is not a radiation yes-no question. This is a regional lymph node radiation yes-no question. So no added value of regional lymph node radiation. Of course, the number of isolated recurrences there, the distant-free recurrence, there is no difference. Disease-free survival and overall survival, no difference. So it shows us that there is no difference by adding regional lymph node radiation, yes or no. Toxicity was, as expected, slightly higher with adding regional lymph node radiation, but not that significant. So the conclusion from the trial is that patients with a node-positive disease converted to node-negative had no improvement of adding regional lymph node radiation. However, just keep in mind that we know that regional lymph node radiation might have actually a long-term investment rather than a short-term investment. Knowing that a lot of those recurrences can happen late in the years after the primary diagnosis. Not only that, as I mentioned to you, there is data supporting adding regional lymph node radiation in node-negative patients. This is, of course, in the upfront. This is based on the very well-known MA20 trial and the EORTC that showed that node-negative patients had actually a high improvement in outcome. Again, you have to keep in mind, we cannot generalize what we're saying it's all individualized. So this is actually from the EORTC with the long-term outcome showing no difference in toxicity. So the value of regional lymph node radiation is actually showing that there might be a systemic benefit, not just a local benefit by adding radiation, which goes back to the slides I mentioned about adding the importance of regional lymph node radiation compared to mastectomy, breast conserving surgery with adjuvant radiation versus mastectomy in breast cancer patients. So again, the data to omit radiotherapy in neoadjuvant patients is very limited. B51 shows us the best. So the study, best, but it's an abstract only. It is just for patients with N1 disease. It does not have N2, N3 that converted to N0. This study was not designed, nor it was powered to address the question of PMRT, post-mastectomy radiotherapy. You have to keep in mind that young triple-negative patients were underrepresented to consider this as a rule. And very important, what I mentioned to you is the tumor location. The B51 did not stratify how many patients had an upper inner or lower inner quadrant diseases that can drain to the internal mammary chain lymph nodes before draining to the axilla. That's why, if you want to follow the guidelines still say you cannot omit radiation. So unfortunately, 60% of the audience here are not following the guidelines and can be medically liable on any patients who would not receive leave the question to the end. So again, this is the debate, and I think this guy looks like someone who's sitting on chair right now, showing that radiation does have benefit. You cannot omit it for everyone. However, my real conclusion is that there is no debate. It is an evolving topic. As a radiation oncologist interested in breast, I have to admit that yes, systemic therapy is playing a bigger role, and it's we're seeing much more complete response. We are in the era of de-escalation. However, we have to be very careful. We have to do it stepwise, and we have to do it carefully. We cannot de-escalate 3 different modalities together. We cannot de-escalate surgery, chemotherapy, immunotherapy, and radiation together, because any cancer recurrence has a worse outcome. We do need longer data. And of course, we need to be very careful in interpreting data. When we interpret data, we have to look at, was this trial powered to address Dr. Saeed's question or not? And finally, we have to individualize treatment. It's no one size fits all. You need to have a trust in a good radiation oncologist. You cannot, just say to the patient, my recommendation, my final conclusion is that have a good radiation oncology team, refer those patients to the radiation oncologist, let the radiation oncologist give his or her input for this patient, because at the end, this patient could be you or your family member, and you don't want recurrences, even in the setting of complete pathological response, which you are seeing more and more common. With that, I would like to thank you all and hope to see you soon. Thank you.
Right, thank you very much indeed, Ibrahim. Okay, so the question was about this one, but again, like Ibrahim changed the question, I decided also to change it. So the real question is actually, should we personalize adjuvant radiotherapy based on PCR to neoadjuvant therapy in early breast cancer? And my answer is actually yes. So how did we actually start this fight? So to take you to this one, I'm just going to use this brave heart. You know this William Wallace, who was against King Edward I. Yeah, and obviously he is the king because he's CMO and he has all the Burjil people sitting and supporting him. And basically, I posted an innocent question, and that was on the 17th of December. Who is happy to omit radiotherapy in node-negative stage 1, node-negative stage 1 triple-negative breast cancer, who has had PCR after neoadjuvant chemotherapy and breast conserving surgery? And then Ibrahim said, not really. Yet again, a great topic to debate. Love how much medical oncologists are in hurry to cancel out radiation. But when things go south, radiation is usually the way out. We will see about that. But I'm actually interested. I'm actually interested in that thumbs up, which is from Dr. Hassan Ghazal, who acted like Robert Bruce, who actually at some point basically went in alliance with King Edward I. But we'll see. So let's have a look at the general data. So the general data that Dr. Abu Ghaida presented was the early breast cancer trials, which obviously does show benefit for adjuvant radiotherapy. However, if you look at the subgroup analysis, you see that patients who are above the age of 70 and node negative, they are less likely to actually derive any benefit from that one. That is 14,342 patients. We have the prospective trial at the moment. Again, it does show a small benefit even for older patient node-negative disease, although it doesn't show there is any overall survival difference for this group of patients. So you see that there is a little bit of conflict actually whether older patient, node-negative patient, they are going to derive benefit or not they're going to derive benefit from having adjuvant radiotherapy. We can again look at the database analysis. You can see that patients with T1 to T3 after neoadjuvant chemotherapy, whether they had breast conserving surgery or mastectomy. And the top one is the mastectomy. You see that there is an advantage for having radiotherapy. However, that advantage is lost for patients who have breast conserving surgery. So these studies, they are basically, majority of them, they are old, different and old surgical techniques, no analysis of the biological subtypes. They look at any recurrence rather than local regional recurrence, and they are not based on the new medicines that we use. Obviously, radiotherapy is not without side effect. It comes from cardiac side effect. You can see that it ruins the look of the chest wall, and it can come with pneumonitis as well. We have actually data to de-escalate radiotherapy. You see that, even in this ESMO, we have data on hypofractionated radiotherapy, which actually works very well, like in normal radiotherapy. But unfortunately, this data shows that even in the US, our radiation oncology colleagues, they are very reluctant to use hypofractionated. You see only around 10% of the patients, Dr. Abu Ghaida, they use hypofractionated radiotherapy, as opposed to a lot of radiation oncologists, they prefer to give normal dose radiotherapy. But the question is that now we have used neoadjuvant chemotherapy, and it does downsize the tumor, it downsizes the axilla, we can monitor the response in real time, and it allows us to do the genetic analysis to the point that Dr. Sohan just was mentioning, if we need to do a mastectomy for, and then it allows us to do micrometastatic disease treatment of the patients. And the PCR has actually shown to improve the event-free survival and the overall survival, and it is accepted as an endpoint by the FDA. But also you can look at this, the effect of the neoadjuvant chemotherapy on the type of surgery. This is for HER2-positive disease, by the way. You see that patients who had neoadjuvant chemotherapy and they had breast-conserving surgery, they did much better than those that they did mastectomy as well. So, having a PCR and having a limited surgery is actually better than doing the mastectomy. So now we have safely de-escalated surgery from mastectomy to go to breast conserving. We have safely de-escalated ALND to SLNB and targeted therapy. We have systemic therapy from the adjuvant treatment to endocrine therapy based on that. We are using Oncotype DX to de-escalate the chemotherapy. And why not we actually try to de-escalate adjuvant radiotherapy based on the PCR? What is wrong with this? But to answer that question, we first need to find the benefit of adjuvant radiotherapy in patients who achieve PCR. And look at this one. This is a combined data from NSABP-B18 and NSABP-B27. So all of these patients, they receive radiation to the chest wall. They did not receive regional nodal radiotherapy. So in NSABP-B18, we had a group of patients receive neoadjuvant chemotherapy followed by surgery, around 760 patients. And NSABP-B27, around 2,346 patients, they received neoadjuvant chemotherapy. So we have in total around 3,000 patients to analyze. Right, so let's have a look. So you can see that this group of people who have complete PCR in the breast and the node, they do actually very well. Look at the rate of the local regional recurrence. This is the local regional recurrence of the disease. You see, it is their very, very small rate, regardless of whether it is breast conserving surgery or the mastectomy. Again, look at how low is the rate of local regional recurrence if you have a mastectomy and if you have a PCR in the breast and also in the nodes. And then look at those patients, whether they are node positive or node negative, the rate of recurrence in the lymph nodes, they are actually zero. There is nobody's actually having any recurrence in the lymph node. So is it actually biology of the tumor that is dictating the risk of the disease coming back? Or is it the adjuvant radiotherapy that Dr. Abu Ghaida is applying? So to answer that question, we need to have a look at some retrospective data. One is this one, which is basically looking at Oncotype DX in NSABP-B14 and NSABP-B20. You see that, if you look at the ones that we have a low Oncotype DX, if you are receiving placebo, around 10%. If you are receiving tamoxifen, it is becoming low, 4%. If you are receiving tamoxifen plus chemotherapy, it is literally become 1.6% the risk of local recurrence. So it is not actually the radiotherapy that reduced the risk of local regional recurrence, because everybody received radiotherapy in that group. So it is actually our systemic therapy, endocrine therapy and chemotherapy that reduce the risk of recurrence of the disease. Look at this one, SWOG S8814. And you can see again, the ones that with a low recurrence score of 0 to 17, they do much better. So these are the patients with 1 to 3 lymph nodes, and literally it is almost zero risk of local recurrence of the disease. Yes, if you have more number of lymph nodes, you have, and then there is a difference between low and high recurrence score. So it's actually the biology of the disease that dictate the local recurrence of the disease. Let's have a look at Trifina and Neosphere. These are HER2 positive disease. Again, we have 312 patients. They had around 172 patients. They had nodal response, and around 140 patients, they did have some residual disease. So the patient, they had a PCR. There is no difference in terms of local regional recurrence. And all of these patients, they actually received the chest wall plus nodal radiotherapy as well. So again, this is another point to mention. Let's have a look at the national case database study. Around 5,383 patients. You again see that there is no difference in terms of survival of patients, whether they have a radiotherapy or they do not have a radiotherapy. Look at this one. This is a post neoadjuvant chemotherapy and mastectomy. Now we have a group of patients triple negative, HER2 positive, hormone receptor positive. If they have a PCR, literally zero local regional recurrence. 0 out of 13, 0 out of 11, 0 out of 8. They do not have any local regional recurrence if they have a PCR. If they have a node negative disease, again, zero risk of recurrence of the disease. Again, biology of the disease, it is very, very important. It is not local regional radiotherapy that we are applying. It is having a PCR. So if Dr. Abu Ghaida doesn't actually believe those data, I encourage him to listen to his colleagues at the American University of Beirut in Lebanon, who looked at Beatrice trial, triple negative. So this Beatrice trial was actually 2,591 patients. They had a standard chemotherapy plus bevacizumab. And again, look at this. These patients, they had mastectomy, the PMRT, no PMRT. Absolute zero difference between the two. So completely overlapping this one. And in fact, they concluded that PMRT benefit in triple negative breast cancer treated with modern systemic therapy is lower than historical report. Delivery of PMRT in patients with N1 disease enrolled in the Beatrice trial was not shown to improve local recurrence. So, do we have any prospective trial as well? So all of these things, retrospective trial, B51, Dr. Abu Ghaida gave a very nice overview of this one. I'm not going to actually mention all of these things. He actually did not mention one thing. He did not mention that around 78% of these patients, they had PCR on this trial. And again, the majority of these patients, they actually did very well because they achieved PCR. So there was no difference in the local regional recurrence because of the PCR. And then when you go to the subgroup analysis, here I would like to draw your attention to the triple negative one, which is the only one that is doing better for having no regional radiotherapy on the right-hand side of the screen. So the triple negative one, actually, they did extremely well. Right, we have Lumina trial. Again, Lumina trial, they looked at the Ki-67. And again, you see that these patients over the age of 55, grade 1 or 2, T1 and 0, they literally had a very, very low risk of local regional recurrence of around 2%. I think this afternoon somebody is going to talk about Europa trial. Again, Europa trial, low-risk patient as well, node negative. And you see that ipsilateral breast tumor recurrence is literally zero. Nobody's having any recurrence of the local regional recurrence, zero. There is nobody's having any recurrence of the disease. Now, IDEA trial, again, you know, from the IDEA trial, we know that the risk of recurrence is, again, very low indeed. Around 3% of the patient, they're going to have a recurrence. So there are quite a lot of ongoing trials. They are trying to address whether we can incorporate a genomic score or anything to avoid radiotherapy. And this is one, again, you know, this is the escalating one, which we look forward to basically have as well. Now, coming to the triple negative one, this is the meat here that we need to take attention to. So as we know that Keynote 522, it did show that patients who have PCR, they do much better than the patient that they do not do PCR, whether in terms of the progression of the disease or overall survival of the patient as well. So this, I think, you know, we had a little bit of a flavor of this one this morning. If you look at the patient who have a PCR and RCB 0, literally 94% of these patients, they do not have in any event basically going on, whether it is a local event or whether it is a distant event as well. Now, this is the most important one that you need to take attention to. So this is actually the result of Keynote 522 based on RCB, right? So this is RCB 0, and this is the risk of local recurrence. Local recurrence only in Keynote 522. Every single patient were treated with a standard of care radiotherapy. So radiotherapy was the standard for treatment. You see that the RCB 0 with PCR, 0.6% risk of recurrence of the disease. As we increase the risk, not having a PCR, basically you are having a residual disease, you see that the risk of local recurrence is increasing. So it is not the adjuvant radiotherapy is doing anything. It is actually the PCR is dictating whether I'm going to have a recurrence of the disease or not. So look at that. That is literally increasing with increasing residual disease. So what is the additional benefit of adjuvant radiotherapy here in those patients who receive the neoadjuvant then? So again, you know, looking at pembrolizumab, now we have invented a new medicine. We have added that medicine into this. Look at each of those categories, and then you see that we have increased risk of local recurrence if we do not have the modern treatment. So it is the modernization of systemic therapy that is also avoiding the local recurrence in this patient as well. So again, my question is that what is the benefit of adjuvant radiotherapy in that setting? I think Dr. Arif was wondering whether that was an important question or not, but certainly, you know, these gene expression studies, they're going to help us to identify a group of patients who may have a better PCR. Therefore, we can omit those dangerous radiotherapies that Dr. Ibrahim is delivering to the patient. Now, what does the guideline say then? So the guideline, look at this. You know, this is St. Gallen International Consensus. Regional radiotherapy can be individualized based on initial tumor stage and tumor response to treatment. ESMO guideline, indication and target volume can be individualized based on the tumor stage combined with tumor response. Again, NCCN guideline, in patients treated with preoperative systemic therapy, adjuvant radiotherapy is based on the disease stage at diagnosis and pathology result of the preoperative systemic therapy. And I wanted to leave you with this one, which is from Philip Portsman, actually from ESMO Breast. Radiation in the setting of PCR has to be adapted to post-treatment assessment. Why not? Thank you very much.
Honestly, excellent presentations, both of you. So before we go to the final voting, we want to give you the chance to give your final thoughts, and then we open it up to the audience, and then we vote.
Okay.
Again.
So since actually I wanted to end, but Dr. Saeed insisted, because you know there are only 5 radiation oncologists. Even if BCI is here, there are only 5. They will not know what they voted, right? No one would know. So the majority are medical oncologists, which is fine. Now, what I'm going to say is the following. Dr. Saeed, you're a very excellent presenter, but you have presented, you've mixed ERPR positive, you've mixed luminal A, we're talking specifically about triple negative disease. That's number one. Number two is we did not talk about the location of the tumor. Number three is that, you know, I agree with you, it's about the individualizing treatment, but we could not be really adopting an abstract, which is a B51, which was founded based on the combined analysis of B51 from Mamona's trial that you presented, JCO paper. Now, that being said, despite a very nice presentation, we agree that it has to be individualized. That's why, if you want to do something, you cannot say, are you happy to omit radiotherapy? No. The answer should be, I need to send this patient to the radiation oncologist. They need to look at the tumor. They look at the size of the tumor, the location of the tumor, the age of the patient, the family history of the patient. And my last comment, like, I don't know what kind of radiation are you seeing, man? We don't see this anymore. I mean, this is really outdated. So, you know, I didn't want to put some pneumonitis pictures from Pembro, but we do see pneumonitis as well from Pembro. But that being said, no, it was a great talk, great talk. I still would offer radiotherapy. I will not omit radiation in a lumpectomy patient. There is no data whatsoever to omit radiation in a lumpectomy patient. So we cannot omit it. In the setting of post-mastectomy based on the B51, I would individualize the treatment, but I would really look carefully at the location of the disease. So it's like when you give a Panadol, you measure the risks and benefits. But great talk, thanks.
Yeah, everybody, and thank you, Ibrahim. I think, you know, this was a great debate. I don't think that, you know, we are yet ready to have the full answer for this one. There are quite a lot of evidence against giving adjuvant radiotherapy to prevent local regional recurrence in patients who have PCR. Look, you know, even the small 2-3% benefit that we are getting from adjuvant radiotherapy may actually be cancelled by some of the new medicines that we have, such as the one that we just heard this morning, like CDK4/6 inhibitor in the
triple negative
adjuvant setting. Again, you know, with the immunotherapy and everything as well. So I think, you know, we will definitely be moving towards personalizing radiotherapy. I think, you know, personalizing radiotherapy, in my view, PCR is one of the greatest biomarkers. We will need to find a biomarker of response, and hopefully, you know, less and less ladies have to go through radiotherapy with those horrible pictures.
Great, thank you.
We give you the chance to defend yourself. Now audience. Okay.
Thank you so much, both of you. Really enjoyed the discussion. I hope Dr. Aida will agree with me that EOS will still encourage their members to refer patients for radiotherapy and not go against the international guidelines. So radiotherapy is a standard of care. Dr. Rafi has misguided the audience by mixing.
Thank you.
By number of things. Once he wasn't sure when he put data for Prime 2 study from
Asian oncologist disguised in medical oncology.
Well, it's about knowledge, Dr. Rafi. So the data you presented.
He is not BCI,
Rafi,
by the way. He is not BCI. Just for your information.
Yeah, the data you presented, Dr. Rafi, just for the all audience, he mixed between, from Ian Kunkler, from the Prime 2 study, you mixed between ER negative and ER positive. The same study talked that the minute you have ER less positive, it's very risky to omit radiotherapy. And that was the message from Ian Kunkler, the paper you showed. It's not about this arguing.
I showed you keynote 522 per each stage per RCB. You see that the more residual that we have more risk of recurrence of the disease.
Believe me, from someone who knows William Wallace very well, spending 25 years in Scotland, so I can talk on behalf of the country. But we really have to be careful about what omitting without randomized data and without changing the international guidelines.
Thank you, Dr. Hussam. Dr. Nuhan.
Actually, you know, I agree with you. Where does biology and anatomy meet? But the question is, who gave neoadjuvant chemotherapy for stage 1 in the first place? And most of the data both of you presented were not stage 1. If anything, stage 1 maybe represented, maybe I quote one statistics, less than 10%. So how can you draw conclusions on the paucity of data here?
Exactly. You cannot. So you have to offer radiation.
Yes, please. Yes. Actually, depend. No. So, excuse me. No, not necessarily so, because if it's a stage 1 disease, and I did the mastectomy for small tumor and node negative. Sorry, Ibrahim.
No, we don't. No. We will not. I'm talking about node positive.
Lumpectomy is standard of care.
We do
Standard of care.
still have data for T1CN0 to give neoadjuvant chemotherapy, and I think it is also recommended by some of the guidelines and consensus as well. So again, you know, this group of patients, you know, the question is that if we do and if they achieve PCR, why on earth we are over-treating them with radiotherapy?
You know, with my due respect to guidelines are show of finger. Number two, how can you measure response on an 8mm tumor while giving neoadjuvant chemotherapy? Yes, you can find papers on everything you want, but it's not the standard of care.
Thank you. We have a comment.
Yes, thank you very much, actually, for what's happening here and about this debate. Actually, Professor Dr. Mohanad Al-Ansari, a surgical oncologist using artificial intelligence, virtual reality, robotic surgery in breast cancer and surgical oncology in other parts of the body. Actually, what we succeeded in, and I hope the colleague will agree with me, that we started to write a roadmap by each case in individual using artificial intelligence programs that will give us a roadmap. This is one. And after that, it is seen by an experienced, let's say, 25-year surgeon or oncologist in order to write a roadmap for each case and give it to the family and to the patient. And we succeeded to do that and started to publish our work. Even we are using now avatars, telementoring, supplied with AI. So example, let's say I'm a surgeon in Dubai. I'm sending myself in an avatar form to telementor a surgery or even in the preoperative diagnosis. So what's happening here is a combination of science that we reached in order to reach near perfection in surgical and medical treatment of these tumors. And I hope in doing that, you know, we can give an aid to each medical oncologist or surgeon in doing this. Thank you very much.
Thank you. Dr. Imad.
So I have to declare that I'm a medical oncologist and I voted both for Dr. Ibrahim. So that's not...
Thank you.
So it's not all medical oncologists will vote to omit. And actually, I would like to say to Dr. Ravi, yes, we are thinking about omitting de-escalation, omitting Pembro in the adjuvant if achieving PCR, but for this to answer, we are doing 2 trials to have the answer, yes, to continue or not. So I guess that the only way is to have a trial that would be fitting to omit or not radiotherapy, or again, with lumpectomy, I'm not sure that everyone will be encouraging to enroll patients on this. To omit regional lymph node or not, that's another story. So we don't need to mix between radiotherapy for the breast or radiotherapy for the lymph nodes, the regional lymph nodes. So this is 2 different scenarios. And again, stage 1, yes, we could think, but again, this is another way. But I enjoyed really both presentations. It's really amazing, and EOS for having this such marvelous debate.
Thank you. Thank you. Dr. Sana.
You know, I very much enjoyed both presentations. And Brahim, you are a very good friend, you know, not just a colleague. Dr. Rafi, I really enjoyed the intellectual thought process. However, having said that, both of you debated not stage 1. You debated advanced stage, post-neoadjuvant therapy. For stage 1, considering right now what we have, I'm not sure even neoadjuvant, if it's used, you really need, I agree, both of you said individualized. Stage 1, I think both of you agree most of the time, considering the recent data for node-negative disease, you would not give, both of you. I would consult my radiation oncologist, which I did, by the way, before, and usually, and I know the wise brain Dr. Ibrahim has, he will agree with you not to give. But just quick reminder of all of us, PCR is actually the best tool, cheap tool, to tell you about the biology of disease. when patients achieve PCR, they have inherently good biology. And TNBC patients don't die of local recurrence. They die of systemic disease, which is usually treated by medical oncology systemically. Yes, we do the radiation therapy for advanced disease, but rarely, if ever, you know, for a very locally advanced disease, we get PCR. If we do, to be honest, I am a believer this is good biology. With or without radiation, it's going to be fine. But we do consult with you, Dr. Ibrahim, and I'm sure for stage 1, both of you agree. We didn't listen to a debate about stage 1, but it was actually marvelous debate. Congratulations, both of you.
Thank you. Someone changed that question.
Can I say something?
Yes, Dr.
Being long in the field. First, there is a study after Halsted came and extended radical mastectomy when they randomized the sample, the IMC. I don't know what the name is, but it's called extended Halsted. And they found 25% of the lymph node positive. This is 100 years ago. They found 25% of the lymph node were positive. Therefore, they abandoned that approach. The second, we always debate whether systemic treatment, systemic control is important or local control is important. Both are important. I tell you what, give one lady after 5 years perfectly well and she has local recurrence and see the destruction to her life and her family and everything because of this local recurrence. And honest to God, local control is as important as systemic control. And we achieve that if we well used it. As you said, now we have a lot of advantages, systemic therapy, immune therapy, target therapy. You give 3 years target therapy, you give 10 years tamoxifen, and I would say go 15 years for tamoxifen to keep the patient under control. But we need to select and look into the new advances in medicine. And sorry, Saeed, the picture you showed, I used to see them in the 50s, not now. And even when I was at Tawam and we had Cobalt machine, we saw these pictures, but not now. With VMAT, with IMRT, with all the techniques, you know,
Deceiving pictures.
And hypofractionation is the standard now everywhere, 40 and 15 fraction, and a boost, yes or not. So there is a modification on our side as radiation oncologists as well to accept few facts that you do very well in systemic disease, but give us the chance to control local disease as well.
One thing, Aida. So now I know how this medically oncology driven. So the question is changed. The question was for so it was omitting radiotherapy in triple negative disease after complete pathological response. Now, no negative stage 1. So there is a change in question. So audience, don't be this.
That is even better because we have data for more advanced disease as well.
This is deceiving. This is fraud.
We saw the WhatsApp message that you wrote.
Brahim, it's not about changing the question. It's about treatment of stage 1 with neoadjuvant.
The question, Dr. Nuhad,
you do it or you do not.
The question wasn't stage 1. غيروه عشان هو
No.
They changed it.
The question is it beneficial to give neoadjuvant to stage 1 disease? The answer yet to be proven. The answer today is no.
Yes.
That the question is about having a PCR, as Dr. Sana said here.
If you give it.
I think,
if you give it.
There are research, as I showed you, everything, regardless of the biology, regardless of subtype. I think, PCR is a very, very good prognostic factor.
If you give neoadjuvant, I'm questioning the very word of the question.
Dr. Nuhad.
Do you give neoadjuvant in stage 1?
No need. So that's why actually the real question, غيروه, Doctor. The real question is
about this.
I think I'll have to end this discussion. I think I have to kick in and end this discussion. Beautiful debate, as always. Honestly speaking, I think both of you are winners. And we all agree that personalized... So one final vote. I mean, you can decide what question you have.
They voted from the beginning. They're even more convinced. Ibrahim, come on. I can't.
Can you stay, please, for the group photo?
We invite everybody on the stage.
We'll do it later.
Thank you very much.